Before I start, let us observe a moment of silence as a mark of respect to the departed soul, Dr. Professor C.K. Dhanasekaran, who was founder member of our Association of Oral Maxillofacial Surgeons of India, one of the 5 members who started this association, and who was a pioneer in oral maxillofacial surgery from India. A minute of silence. Thank you. Thank you, dear colleagues. He passed away yesterday on the day of International Maxillofacial Surgeons Day. We have a senior professor, Professor Prabhu, with us to share a few words about his mentor and teacher, Professor C.K. Dhanasekaran. Sir, Prabhu, sir. Sorry, yes, we have. He's got some technical issues, I guess. Okay, yeah. Now, let me invite the principal of Dean of Vinayak Mission Dental College to share a few words.
Thank you, Dr. Jimson. Hope I'm audible.
Yes, sir, you're audible. Yes.
Yeah. Distinguished speakers of the day, Professor Paul, Professor Andy, Professor Veerabahu, and Professor Vijay Kumar, and the office bearers of Tamil Nadu chapter of OMFS, and the other delegates who are eager to hear the lecture today. A warm welcome to you all. I'm really happy on behalf of Vinayaka Mission Shankaracharya Dental College to be part of the Tamil Nadu chapter of oral and maxillofacial surgeons. At this outset, let me congratulate this chapter because amid this pandemic, I have heard and seen a lot of lectures that has been happening during this time. I think the appreciation has to go to the office bearers, especially Dr. Jimson and the other people, executive members who are involved in this. Now, having an institution with a specialty is something which is very, very welcoming note for all of us, especially the institutions will be benefited much. And, you know, we can have a lot of international exchanges and knowledge sharing and as well as the handwork or clinical experiences between ourselves. So I'm sure that today's lecture with these eminent speakers will be of great importance for all the oral and maxillofacial surgeons who have joined now. So I wish you all the best and I thank you for inviting me for this. Thank you.
Thank you, Dr. Baby John, for your kind words.
Thank
now,
you.
may I invite the Dean of Tagore Dental College, Professor Chitra Chandran, to share a few words. Yes.
Good morning. Good morning to our dear speaker from UK, and good evening to a speaker from Australia, Dr. Paul, and good afternoon to all my colleagues in India. It's indeed a privilege to be here among the oral surgeons. Oral surgery is one of the leading branches in dentistry, making big strides and making a lot of research and going forward. and the Association of Oral Maxillofacial Surgery of Tamil Nadu and Pondicherry has been very active during this pandemic period, conducting a lot of webinars and also live workshops for the students and for the staff to improve their knowledge. And under the head of Dr. Jimson and other office bearers of this association, I thank each and every one of you all for organizing these programs for the benefit of the students and the staffs. Yesterday, they launched a book also, online book, which will be very useful for the postgraduates and not to say undergraduates as well, and general public, general dentists. This comes free for anybody. It's a great effort by the association, and congratulate everyone who participated in this effort. I'd like to welcome Dr. Andy from UK, Dr. Paul from Australia, who had come specially for this, who joined us specially for this program. COVID has become a pandemic period has become a very useful period for all of us to reach out to speakers all around the world. In one way, it's been benefiting us. And Dr. Veerabahu, my close friend and my colleague, thank you. It's always been a great help to our college. Dr. Vijay Kumar, Vice Chancellor of Yenapoa University, thank you, sir, for being with us. And it's a privilege for Tagore Dental College to be associated with this Association of Oral Maxillofacial Surgery. And the strikers, the group, they've been very helpful and very helping all the association activities. And I thank them also. And I wish all the students and staffs who joined for the webinar a good day. And I thank the association for involving us. And thank Dr. Jimson for involving me in this program. Thank you, one and all.
Thank you, ma'am, for your kind words. Now, we have a short release of the newsletter. I invite the editor, Dr. Kannan, to present the newsletter to us.
Yes, sir.
Dr. Kannan is the editor of our state branch, who has been working wonderfully well and he has put in a lot of efforts to get this newsletter released. Over to you, Kannan. Kannan? Kannan, are you able to share your screen?
He left, it seems, sir.
Okay, no worries. Okay, and then we'll start with the program now. We have two moderators, Dr. Reena John and Dr. G. Padmanabha Kumar from Masa University. Dr. Padmanabha Kumar is an oral surgeon who did his undergraduation and post-graduation from Ragas Dental College, Chennai, who has been my junior in college and student of Professor Veerabahu. So, and now, right now he's working as an associate professor in the Faculty of Dentistry, Masa University, Malaysia. And the other moderator of the day, Dr. Reena John, who does not require any introduction. She is the president of our state branch and she is the associate dean of research at Vinayak Mission Sankaracharya Dental College, Salem. Yes, ma'am, I think before we start, we have Dr. Prabhu here. Sir, Prabhu, sir, are you able to hear us? Can you unmute? Sir, Prabhu, sir?
Yeah.
Hello.
Yes, sir, we can hear you, sir.
Yeah.
Yes, sir. A short tribute.
Hello.
Yes, sir, we can hear you, sir.
Yes, sir. With the profound grief, we lost the greatest man of Tamil Nadu in the field of oral and maxillofacial surgery. Particularly to me, it is a great loss that as if I have lost my father, because that was PG. When I was doing my post-graduation, I lost my father, and he really took care of me as if I am his own son. And he still calls me Sonny. He calls me only Sonny. And you know what sort of moment I will be in. But he is a great man, a philosopher, a guide, godfather to everybody, particularly in the field of oral and maxillofacial surgery. And his death on the Maxillofacial Surgeons Day, International Maxillofacial Surgeon Day, is really apt. Correct. Every one of us, death is a life cycle. Anyway, it has happened on a great day for that great man and the great soul. I think I do not want to take much of your time in this webinar. And with these words, I think we should all join to do something in the name of Dr. C.K. Dhanasekaran, particularly an endowment to support a postgraduate. I think I will take the early steps to that along with Dr. Professor Beg, and then get back to you soon on 21st, and then I'll give you everything on 21st when we are having a condolence meeting. Thank you.
Thank you, sir.
Thank you, sir.
For those words. It's a difficult time indeed for you. Okay, yeah. Let's start with the program. Over to you, Reena ma'am and Kannan.
Yes, sir. Was I audible or not, sir?
Yeah.
Okay, sir. Thank you, sir. I'm leaving, sir.
Yes, ma'am, you can start the presentations.
Thank you, Dr. Jimson. So I understand that Dr. Kannan is not presenting the newsletter, or has he finished that?
Some technical issues. So after the program, at the end of the program, we'll try to,
Okay.
we don't want to delay the program further.
Yes. So thank you, Dr. Jimson. It is indeed a privilege to introduce the two eminent panelists of today, who I have been given the honors of introducing. So the first panelist that I am supposed to introduce is Professor Dr. Paul Sambrook, who has graduated from in the year 1985 and then went on to postgraduate in the year 1990, along with his fellowship from the Royal Australasian College of Dental Surgeons in 1990. He went on to get his medical degree in 1993. He has been the director of Oral and Maxillofacial Surgery Unit in the Royal Adelaide Hospital, University of Adelaide, and a visiting consultant to a number of major public hospitals and a busy specialist practice. He has got a busy specialist practice. He's been the president, he is the president of the Royal Australasian College of Dental Surgeons. He is the president of the International Board for the Certification of Specialists in OMFS. He's the past president of Australian and New Zealand Association of Oral and Maxillofacial Surgeons. He's an EC member of the International Association of Oral and Maxillofacial Surgeons. He's a speaker both at the national and international forum. Professor Dr. Sambrook, you are more dear to us. All this and more, I'm sure, is part of your CV, but you are more dear to us, and you've become part of us because of your constant support and presence in all of our webinars, always there, giving us a few words of encouragement. That means a lot to us. And it is indeed not only my privilege, but I'm really honored to be introducing you today. I do not know whether I've done justice, but I've tried my best to say whatever I've got from the short CV that Dr. Jimson has shared with me. Professor Dr. Paul Sambrook, welcome to this webinar.
Dr. Reena, ma'am, thank you very much. It's most humbling. Thank you very much.
Thank you, sir. So the next panelist that I have the honor of introducing to all of you is Professor Dr. M. Vijay Kumar. It's with awe that I am introducing this person, because he's a giant, a huge person by himself. He's a Vice Chancellor of Yenapoya, deemed to be university, Professor of Surgical Oncology, Yenapoya Medical College, Mangalore. He graduated way back in 1979, and he went on to do his DNB in general surgery in 1985, went on to do his MCH surgical oncology in 1993, and he just did not stop. He went on to do his fellowship from the Royal College of Surgeons, Glasgow in 2007. He took over, or he started work in the Gidwai Memorial Institute of Oncology from 1984 and continued till 2015, and took a voluntary retirement as the head of the department. And he was also the director for 5 years of the same institute, Gidwai Memorial Institute of Oncology. And he didn't sit there quietly as a director, but he elevated the institute from a regional center to a state center institute recognized by the government of India. He's got a long, I think even the brief CV that Dr. Jimson gave me is so long. And if I go on, I think I'll encroach on the time for the webinar. He's been the honorary secretary of the Indian Association of Surgical Oncology in the past, and the president in 2015. He's a vice president of Osteomaths India, and he's been a national and international speaker with many presentations and publications to his credit. He's been an orator at the state and national level. He's been awarded many awards, and nothing stops him. I was surprised to see that in his CV that he is trained in robotic surgery recently, and he has established it also in the Yenapoya Medical College. That is a glimpse of who Professor Dr. Vijay Kumar is, all for you. The two panelists who are going to speak to you, ladies and gentlemen. Thank you. Thank you, Dr. Jimson.
Yes,
Thank you, Professor Reena. Now I take privilege to introduce our professors, the next two panelists. First, it gives me more pleasure and happy to introduce my teacher, Professor M. Veerabagu. Professor Dr. M. Veerabagu completed his BDS from Governmental College, Chennai, and completed his Masters in Oral and Maxillofacial Surgery from Governmental College, Trivandrum, Kerala. He had his extensive training in cleft lip and palate surgery from under the able guidance of late Professor Aidan Wala. He joined Roberts Dental College in 1993 and started his academic teaching career. And from then onwards, he started inspiring many junior lecturers, junior trainees, and so many students, including me. He has held various positions in AOMSI, that is Association of Oral and Maxillofacial Surgeons of India. He was the chairman of Indian Board of Oral and Maxillofacial Surgery, and now currently he is the president of the association. Under his able guidance, the association is achieving greater heights. I wish you all the best, sir. And then he has published numerous articles and research papers in various international journals. I take privilege in introducing Professor Veerabagu to the international faculty, to the international webinar.
Thank you. Vatana Kumar, such a wonderful, nice word, kind words. Thank you.
Always your blessings. Thank you, sir. Now again, it gives me a great pleasure and privilege to introduce our Professor Andy Edwards. Mr. Andrew Edwards, born in Dundee, Scotland, he completed his basic degree in dentistry in 1987. a period of junior positions in oral and maxillofacial surgery, followed then by gaining FDS from the Royal College of Surgeons and Physicians of Glasgow in 1993. He went to medical school, qualifying his MBBS from the University of Aberdeen in 1998. His basic surgical training was in the west of Scotland, admitted as FRCS in general surgery of the Royal College of Physicians and Surgeons of Glasgow in 2001. He went on to his higher surgical training in OMFS in the northwest of England, gaining the intercollege fellowship in OMFS in 2006. He spends a period working in South Africa as a visiting registrar at the University of Pretoria, gaining valuable experience in facial trauma. He is currently the consultant oral and maxillofacial surgeon at the Royal Preston Hospital, specializing in the surgical correction of facial deformity and facial trauma. He has delivered numerous talks nationally and internationally on education and on various topics. On his own clinic, he has his own clinical practice within the Royal College of Physicians and Surgeons of Glasgow. He is currently the Dean of the Faculty of Dental Surgery and Vice President of the college. Sir, Professor Handy, we take privilege in welcoming you for this webinar.
Thank you very much indeed for these kind words.
Welcome, sir. Especially for spending your early morning Sunday for us. Thank you so much. So now we'll start with the first webinar by Professor Handy Edwards. The topic is golden hour in maxillofacial trauma. Sir, Professor, the screen is yours.
Excellent. Good morning to you all. Could you hear me and see my screen, hopefully? Everybody's saying no, which is always a good sign. Yeah, excellent. Marvelous. Yes, well, very, very good morning to everybody, and a very good afternoon and a very good evening. It's very, very privilege for me to be here again speaking to you all. Many thanks to the two co-chairs for their very kind words. I'd just as well like to pass on some condolences from the maxillofacial surgeons in the UK. You heard some very kind words about C.K. Dansakaram, and I didn't know the man, but I believe he was held in very high esteem in India, and I'd just like to pass on our condolences from the OMFS colleagues in the UK as well. I'd like to thank President Veerabuan for inviting me, and in Wales, Jimson as well for getting me up early again on a Sunday morning, which is always fantastic. Many thanks to the two deans again for their invite as well, and it's great to see that you had a fantastic day yesterday launching your first OMFS book, and I was able to take part in it as well. So thank you very much indeed for giving me the honour to speak to you today. The topic I'm going to speak to you about is the golden hour in maxillofacial trauma. And you're going to think, well, how does a golden hour affect maxillofacial trauma? Well, it does. I'm going to give a little bit of an overview of it, how it affects maxillofacial trauma. And also as well, I'd just like to give you a flavour of how we deal with major trauma in the UK, the establishment of major trauma centres, and telling a little bit about what we call mass casualty events, which unfortunately in this day and age are becoming all too familiar to us throughout the globe, basically. So trauma, it's been around for a long, long time. It's a huge problem, both financially, holistically, physically, mentally as well. But you can see just some of the numbers there. 6 million dying per year globally from injuries, 16,000 people per day worldwide as well. But the permanent sequelae is huge. Trauma actually kills more people than HIV, TB, and malaria combined, which is surprising in this day and age as well. In the UK and in more of the developed countries, our leading cause of facial trauma, as we all probably know, are motor vehicle accidents, probably pedestrian collision stumblings and stuff like that as well. But as I say, the leading cause in underdeveloped areas is the road traffic accidents, followed by assaults as well. So we are seeing a slight change in the pattern of the way trauma is and the way trauma happens, basically, particularly with maxillofacial trauma. So what is this golden hour? What are we talking about when we talk about the golden hour? Well, this phrase was coined, way back in the sort of 60s, really, by this chap, Dr. Adams Cowley. He was a trauma surgeon, an orthopedic trauma surgeon. And he developed this in America, and he's known as the father of trauma medicine. He established the shock trauma unit at the University of Maryland in Baltimore, and that was established way back in 1958. So he's seen a need that there was for trauma and the appropriate management, and in particular in pre-hospital management and assessment of trauma. He was the one that first used helicopters for evacuation of civilians, and they're not talking about military here. This is for civilians back in the late 60s. And he used the First Nation statewide EMS, which is a emergency medical services, in the way back in the early 70s. So he coined the phrase, the golden hour is the hour between life and death. If you're critical injury of less than 60 minutes to survive, you might not die right then, but there may be 3 days to maybe 2 weeks later. But if something has happened to your body that's irreparable, and basically they sort of summed up there that the first hour after injury will really determine your outcome, really, and your chances for survival at a later date. So that's essentially what this golden hour is, basically. Now, we are in the world of epidemiology, and we know trauma deaths is a sort of trimodal distribution of trauma deaths. You can see there 50% of deaths are within what we call immediately, 30% happen within hours, and 20% happen further down the line in days and weeks. And this golden hour is dealing with that first 80%, the immediate, and the 30% in the hours after impact. However, what can we do about the immediate? Well, not a lot, really, because these are catastrophic injuries, really. These are, something like a decapitation, a significant blast injury, for example, whereby you've got significant catastrophic hemorrhage, you've got significant neurological injury or spinal cord or a suffocation. So these are immediate injuries, which we can't do anything about. They happen instantaneously, for example. The ones we're looking at are the early ones. They happen within hours of the injury. And they're roughly about 30% of these deaths. And most of them are about 50% of them, probably more now, are caused by hemorrhage, and the other half really by what they would call a neurological insult. And these ones are the ones that they're targeting when we talk about the golden hour. The late peaks of the other 20%, and that's the ones that tend to succumb to things like sepsis or multiple organ failure, and that's further down the line. We live in evidence-based medicine and evidence-based surgery, evidence-based maxillofacial surgery, and we can see there that there is evidence. This chap Sampoulos quoted quite a few papers that looking at pre-hospital time, and if it was over 60 minutes, you had a significant increase of dying, basically. Your mortality rate was significant. And again, you looking at the pre-hospital time, again, if you reduced that, your risks of dying were reduced. They were actually quite crude, these figures, when they done it. They were looking at the severity of the injury and the age of the population. A couple other studies were done, 2002 and 2005, and again, looking at the response time. And again, they looked at the survival rate when they looked at response time, and you got the response time into 5 or 4 minutes. However, it's all not clear cut like that. We're all not saying the golden hour is a fantastic thing. There's a lot of evidence against it, basically, or what they call inconclusive evidence. There's a lot of studies. The main one's the one at the bottom of your screen. This was quite a significant study because it looked at 51 trauma centers throughout the part of the USA or North America. And they actually established no relationship between the interval time for the emergency medical service response and the actually mortality amongst the injured patients. And this is, we're talking about physiological abnormalities. We're talking about things like hemorrhage, for example, basically. So there is evidence against it as well. So, the jury's a little bit out on the golden hour and does it have any sort of relevance? I believe it does. I'm going to introduce you to another concept as well here that you may well have heard of. Now, way back in the mid-70s, this was Dr. James K. Steiner. He was an orthopedic surgeon and he was a pilot as well. And he was ferrying his children back, 4 children and his wife, in his aeroplane in Nebraska, and it crashed. His wife, unfortunately, was killed immediately, as she was within that 50% we talked about, the immediate injury. However, him and his 4 children had significant injuries. He himself had a rib injury, had actually a fractured zygoma. One of his children had rib injuries and fractured limbs. they actually spent 8 hours awaiting somebody to come and get to them because the mist was so far he couldn't actually see the road. But eventually when he did see the road, they got to a local hospital about 8 hours later. The local hospital was closed. It was actually closed. So they actually had to go and wake up the 2 GPs who manned the hospital and the nurse. But the care was that inadequate. They just didn't know what they're doing. That you actually had to phone a colleague at Lincoln General Hospital and eventually medevaced them out to Lincoln General Hospital, where they actually got a reasonable standard of care. He survived, as did his 4 children. So he developed ATLS, and some of you are probably familiar with this, the Advanced Trauma Life Support. I've gone through it. I'm an instructor on it. I have been for a number of years, but that was sort of the first course was way back in the late 70s, and the American College of Surgeons sort of adopted the ATLS protocol in the 80s, and it's actually gone through worldwide as well. And some of you may well be on an ATLS course. You may well be instructors, and if you haven't, I would certainly commend you to do one. What does it mean? Well, they're sort of broken down into little bits, and MaxFacs, or oral maxillofacial surgery, does dovetail into some of these there. Preparation and triage, that's the sort of pre-hospital event. Primary survey, resuscitation, adjuncts to primary surgery with further resuscitation, secondary surveying, which we get involved in a lot, adjuncts to secondary survey, and then we call post-resuscitation monitoring and what we call definitive care. MaxFacs gets involved in all aspects of that, and depending on where you are and which part of the world and the services that are available, you may well be involved at a very early stage in the primary survey and involved with resuscitation. So what is ATLS? Well, this is a primary survey, and you're all familiar with this mnemonic: the airway with C-spine, inline immobilization or protection, breathing with ventilatory support, not just breathing, you have to ventilate somebody. There's no point in giving them an airway if you can't ventilate. Circulation, again, you've got to establish your circulation, but you've got to control the hemorrhage. You've got to turn off the tap. There's no point in you pouring fluids in or blood in if the tap's still open. Again, disability, we're looking at the neurological injuries, from a neurosurgical viewpoint, and exposure and environmental control is looking at the body in a whole, basically. So this ATLS protocol, so what are we talking about? Well, obviously the first one is airway and maxillofacial trauma. How does this impact on us in this sort of first immediate area, basically, this time that we're dealing with? Well, we all know that if somebody has significant panfacial fractures, the way the inclination of the skull base is, that maxilla can be forced back the way, it can block the nasopharyngeal airway. And also we know that if there's an anterior fracture of the mandible, because of the attachment of the genial muscles, the tongue can actually fall back from its anterior insertion and actually occlude the airway, basically, particularly if the patient's supine. And you often see that when a patient is brought into the they're often blocked with head blocks in, they're often on a spinal board, and they're lying flat, aren't they? They're always lying flat. And that's where the significant risk to the airway is there. And you can see there's a significant panfacial fracture, which has forced the maxilla back the way. And again, you can see there's a midline fracture of the mandible with detachment of the genial muscles. And again, the tongue will back there. So you're getting a double whammy here. You're getting the maxilla thrown back the way, and you're getting the mandible with the tongue falling back the way. So the simplest thing to do is sit the patient upright, and pull on that maxilla, pull the maxilla and pull it forward, and that will disimpact it and create an airway for you. So it's a very simple maneuver that you can do, and obviously a lot of our first responders in our trauma team are very aware of this maneuver there, and you'll be surprised doing a simple maneuver that will actually create an airway, and you'll find the patient isn't hypoxic anymore. Obviously teeth, particularly if there's been a ballistic type injury, bone fragments as well. If they're not in the mouth, where are they? Are they in the airway? No. Are they in the lips? No. Are they in the floor where they've had their injury? So again, always be mindful of there may well debris, which may well be blocking the aerodigestive tract as well. Hemorrhage, I'll talk a little bit about hemorrhage from the open wounds and nasal bleeding. Again, that can compromise the airway. Soft tissue, there's massive soft tissue swelling, which happens quite quickly. And you've seen that when patients turn up to the trauma unit, that causes significant airway compromise, particularly if they've got subsequent laryngeal or pharyngeal injuries to the epiglottis. And that causes significant problems with airway obstruction. a simple algorithm here is to follow this really, and our anaesthetists will follow this. This is something that obviously they're very mindful of, but certainly if there is a couple of things, are spontaneously breathing, yes. If it's normal, you just reassess, but obviously if you anticipate any airway obstruction, nasotracheal or orotracheal. Now nasotracheal might be difficult, but they've got panfacial fractures and the anatomy is distorted, so you may well have to think about orotracheal. There's talk about pharmacological adjuncts as well. We talk about what they call an RSI, a rapid sequence induction. If they're not breathing and unable to intubate, there are various devices available. LMA is okay, but unfortunately it will not protect the airway. Combi tubes to try and retry it. And then ultimately, if we fail there, we've got to go to a definitive surgical airway, which, as we all know, is a tracheostomy, or indeed potentially a submental intubation as well. That's something we think about. So there's some indications for a definitive airway thing, absent spontaneous breathing. Obviously, the patient with a Glasgow coma scale less than 9, that means they're comatose. They're unable to protect their own airway, and I'll talk a little bit about coma scale in a minute. If they're desaturating and their saturation is persistently below 90%, high risk for aspiration, i.e. they're bleeding quite extensively for the facial region. And certainly if they've gone into systemic shock, i.e. the blood pressure, the systolic blood pressure is below 80, that indicates significant catastrophic hemorrhage. And then there's the old adage, cannot ventilate, cannot intubate situations, which means they're looking at securing the airway in what they call a surgical airway. Now, there's only 2 types that we know of. One's a cricothyroidotomy and one's a tracheostomy. Tracheostomy in my books is an elective procedure, although I have done a few in an emergency situation. It's not to be advocated at all. 2 types of cricothyroidotomy we know is the needle one and the surgical scalpel one. I would go for the surgical scalpel one if we were going to go to that as well. How about hemorrhage in this sort of first period, this golden hour? Well, we know maxillofacial injuries can prone to massive hemorrhaging, and it can vary from anything 1 to 11%. And what do we mean by life-threatening hemorrhage? Well, it's a loss of 3 units of blood in about 2 hours, and the hematocrit drops to a level less than 21%. So there are different classes there: class 1, class 2, class 3, and class 4. Class 4 hemorrhage is when you start having significant derangement of the physiological parameters, and we're talking about more than 50%, 40% blood loss here. You've got significant impact on the heart rate, which goes up. The blood pressure starts to go down, particularly the systolic. You then become tachypneic with an increased respiratory rate, often 20 to 30. Reduced urine output, they often become anureic as well. They become obtunded because the Glasgow coma scales come down. And when you're looking at their biochemistry, their base excess, they become significantly acidotic then. And then obviously you have to indicate a major blood transfusion protocol. Now, it's unusual to get a class 4 hemorrhage from the head and neck region. Usually you're thinking that there's probably something in the way of an intra-abdominal bleed, or indeed what we call a compartment bleed, where a lower limb has fractured and there's closed or unseen, or what they call occult hemorrhage. In the maxillofacial region, we know our anatomy. Most of the bleeding tends to come from the maxillary artery, which all its branches there, which supplies the mid-face, basically. It's unusual to get bleeding from the lower part of the facial region, because it's really the facial artery that tends to cause that. So it tends to be the mid-face tends to bleed, tends to be the maxillary artery and its subsequent branches, which supply the nasal region, the nasoethmoidal region, and that's where most of the bleeding tends to come. Even then, you can see in this catastrophic injury here, but there's not a lot of bleeding. You know, the bleeding tends to sort of self-seal itself as well. You can see we've established an airway, but there's limited bleeding, and you often get that with significant facial fractures. That bleeding doesn't tend to be an issue. If it is, however, then how do we control it? Well, pressure packing, that's good old-fashioned way. Reduce the fractures, you know, stick a bite block in there, and that often puts pressure on any vessels that we can't see deep at the back of the maxilla. A balloon tamponade, and I'll give you a couple of examples of how we deal with balloon tamponading. We're privileged here in the unit I work with to work with interventional radiologists who are excellent using angiography. So we can use transarterial embolization, and they're very good. And that's particularly reasonably to use. It's difficult with significant catastrophic mid-face injuries, but if you've got somebody like a knife injury or a significant neck injury with penetrating trauma that's quite specific, then angiography is very, very good at dealing with that. In severe cases, you can go to tie off the external carotid. I've only done that twice in my career, and it's not a thing to be done significantly lightly, and its success rate is not great, to be quite honestly, because of the significant collateral blood supply from the internal carotid. So it's there. How about the nose? This is where most of the bleeding comes from. It's either from the front or from the back. And you can see there, the anterior is actually a lot easier to manage because you can see it and you get into it. This is Little's area, which our ENT colleagues talk about, and most of it comes from there. The posterior is a lot more difficult to deal with, and this is when blood can go back the way. So often you don't see this blood, so it occultly goes down and the patients end up swallowing a significant amount of it, basically. So the first time you're aware of it is when they vomit a significant amount of blood because it's been going back the way rather than through the anterior nasi. So packing, well, very easy. There's lots of these packs available, these rhino packs basically, and they basically put them along the floor of the nose. You inflate it with fluids. Some of them self-inflate, some of them you've got to add fluids, some of them just will float. So there's various packs there, and you obviously have a string because you want to be able to take them out. You want to be fishing for them basically. So that's pretty straightforward. For the posterior bit, which is a more difficult one, Foley catheter is quite good as well to go that. So you can place that along the floor of the nose and inflate it and pull it back into the posterior nasal space. These nasal balloons are very good. There's, again, rhino packs, there's various models around and stuff like that. Essentially, there's two compartments to them, an anterior, a big anterior compartment, which fills the anterior nases, and a smaller posterior pack as well, which can help occlude the posterior nasal pack. So these packs are very effective for nasal hemorrhage, which most of the bleeding will come from when you're got significant facial injuries. These are, as I said, the angiograph with selective embolization. It's just showing you a map of the external carotid and its various branches, but they're very good for what we call penetrating neck injury. If you've got somebody with a stab injury to one of the levels in the neck, for example, or the facial region, and again, when you've got failed nasal packing, you put all your packs in and it's still bleeding, your packs, it's bleeding behind your packs. It's very good to get your interventional radiologist to come along and give you a hand to try and selectively embolize one of the vessels, and the ones we've got in the unit here are fantastic. But about brain injury now, obviously, if they've got a significant maxillofacial injury in this golden hour, they're going to talk about significant brain injury. There are either two types, what they call a vocal brain injury, and you can see there in the middle is obviously, and the one on the right is significant trauma causes skull fracture. That's pretty obvious. Or the other one is sometimes what they call a diffuse brain injury or diffuse axonal injury, where they get this acceleration, deceleration injury, and they get this smart swelling of their brain, basically. So brain injury, you're all familiar with the Glasgow Coma Scale, being a Vice President and Dean of the Faculty in the Royal College of Surgeons in Glasgow. I'm quite proud of it. It was coined by Graham Teasdale, now Professor Sir Graham Teasdale. He was actually president of my college from 2003 and 2006. That's a picture of him there, and that's the portrait that hangs in the college of Sir Graham. And you're all aware of the Glasgow Coma Scale and how to use it, basically. Lowest point is 3, not 0, as a lot of people think, and 15 is the top one. Anything below 9 is what we call coma, and then it's divided into 3 to 15 for minor brain, moderate 9 to 12, and severe brain is less than 9, which is comatose. So it's a very, very good scale. It's been used worldwide. There are modifications of it available, but that's the original coma scale as it was coined in 1974. What are the signs? Well, we all know the signs when you examine a patient, the battle sign and the rhinorrhea. Look for you can see the classic picture here of this sort of straw-coloured fluid dribbling down the nose, basically. And again, the raccoon faces or panda eyes. There's a good chance that there's a skull base injury here. Spinal cord. Now, we tend to forget a lot about these because spinal cord injury, if you've had a significant maxillofacial injury and your patient presents in this golden hour or this first presentation, you're going to be aware of the fact that the C-spine might have be injured. Now, that's difficult for us because as surgeons, we like to move the head. And if, of course, you can't move the head, it's a disaster because then you've got to move it to actually reposition patients, move them off table. So it has implications, basically. And most of the fractures that occur of the C-spine are because of the direct injury to the facial region and also the cervical spine and actually the ligaments that attach it. Most of the injuries can occur high up or low down. So it's either C1, C2, which they call the hangman's fracture, which is catastrophic. C6 and C7, there's a higher chance of survival, albeit with a paraplegia, with disc herniation as well. So that's just a couple of studies that were done showing that the association with spinal injuries is mainly with a mixed pattern, really, with maxillary and mandibular, because that obviously goes hand in hand with the amount of force there. You're going to break more bones. If it's bigger force is a good chance you've got a C-spine injury. And again, as I said before, most of the injuries come either at C1, C2, or you can see there at C5 and C6. This study of Pete Revington and the team came out way back in 2015, and they actually looked at the amount of C-spine injury, CSI associated, was actually quite low at 2.2%. And they looked at all the studies that showed it. So there was from 0 up to 8%, which is relatively low. But I was reminded of this on Friday. This was a patient who was part of the mountain rescue team here in the northwest of England. I won't tell you the circumstances, but we're meant to have a lockdown here in the UK, and there was an idiot who went out, decided to go on the hills for whatever reason, and he got lost, and they had to send the mountain rescue people out. This is a mountain rescue gentleman who was part of the team, and he fell 200 feet down a mountain, survived. But you can see there he's got significant panfacial fracture, 4, 2, 3, call it whatever you want. However, the reason we couldn't go in to fix his face straight away was that. So you can see there significant C6, C7 severe distraction and transection of the cord, basically. So this gentleman, unfortunately, is paraplegic now because of the injury at C6, C7. So just be very, very mindful of that when you do go in to examine the patients of a C-spine injury. I mean, obviously the mechanism of injury here, a fall off a mountain, is going to cause significant amount of injury, not just to the facial region. He suffered multiple other injuries as well. But we fixed him on Friday after his C-spine fracture had been treated. He had that treated as well, but we managed to treat his facial fractures on Friday. Couple of cases. This, I mean, what have we done here? Well, we've secured an airway. It's massive what you think, tissue loss. But again, we've controlled the hemorrhage. Now, a couple of nasopharyngeal airways are very, very good as well to pop them in, and they just help placing things like, for example, packing or Foley's catheters. So they're very, very good, but you can see the amount of swelling it's gone in here. Also as well, anaesthetists are great at putting tubes down, but they often put the tubes down and they take with them a tooth. Now you can see here as well, a tooth ended up in the lung, basically. So always mindful of when the anaesthetist puts his tube in, he's very, very happy that the tube goes in because he's got an airway, but then you say, well, where's this incisor tooth? It was here and it's been forced into the lung. So just be quite mindful of the fact of where teeth are, and a CT scan of thorax will show you, or a simple chest film. Again, look at this guy. This is a guy that came to me, significant, you can see his scan here, significant panfacial fracture. This is his maxilla, and it's completely off-ended. It's hanging on by a thing, pedicle here. His mid-face is just catastrophically injured, and there's a hole in his face here, and you're thinking, well, what caused this? It was a fence post. This guy was driving his car on drugs and alcohol in the middle of the night, went through a field, and a fence post went in his face here. So you can see here the fence post going in, and it's coming out here as well. We secured an initial oral tube, an oral tracheal tube, but we had obviously to do a surgical airway. But there was very little in the way of facial bleeding. So we thought, well, we'll do an angiogram here because I was a bit worried taking this out. what would happen when we got him into the OR. So we took it out, and that's a plank of wood that came out there, which was embedded in his mid-face, and there was actually very little bleeding, believe it or not. So again, just to tell you that, okay, you know, it's a catastrophic injury, but there's not a significant amount of hemorrhage there at all. And this is a very, very localized injury, and absolutely no other injuries at all from that. So just to be aware that even though it looks quite significant, then the bleeding is minimal there. So I'm quickly just going to go through a little bit of trauma management in the UK, how we manage our trauma services. We looked at it in 2012 and we reorganised everything into what we call major trauma centres, or MTCs. There are 27 of them in England we're talking about. I'm not talking about Scotland at the moment, I'm just talking about England. We've got 11 which are mixed for adults and children, 10 for adults only, 5 for kids, and we've got a collaborative centre as well, 1 collaborative centre. What is a major trauma centre? Well, we should be having about 250 critically injured patients, and that's due to the ISS, or injury severity score, and I won't talk to you and confuse you about that, but usually a 3 to 4 million population. It provides 24-hour-day consultant-led resuscitative trauma team. They have all the surgical specialties on one site: orthopedic, general vascular, neuroplastic, cardiothoracic, us, which is part of head and neck, urology, interventional radiology, and anaesthesia with appropriate care facilities. Quick map of England, that's just to show you where they're based. The ones in blue are the adult and children, the ones in green are the adult ones, and the ones in red are the children only one. You can see where I am in the northwest of England. My hospital is number 18. We're in a high density population here in the northwest of England. That's why there's a number of adult and children ones in this radius here, because you've got cities like Manchester and Liverpool here, which has got a significant population in the northwest. So these are the major trauma centres. What happens in a major trauma centre? Busy slide. Essentially, step 1 is to assess their vital levels, assess the anatomy, assess the mechanism injury. Remember I told you this guy fell 200 feet off a mountain. That's a significant injury. He's going to get whisked straight to a major trauma centre because there's a chance is there. Whereas somebody, you know, stumbles out the front door and falls, it's highly unlikely they're going to be taken to a major trauma centre. And again, if there's any special ones. So basically you're looking at coma scales less than 14, low systolic blood pressure less than 90, tachypneic, or anything, and that's pediatric ones, which is a different one. The anatomy, if there's any chest, amputation, penetrating injury, open fracture, spinal trauma, etc., etc. So they're assessed all at the time. The mechanism, I talked to you about traumatic death in the same passenger compartment, i.e. you're in a car and somebody next to is dead. Falls greater than 220 feet, well, obviously falling off a mountain. Trapped under a vehicle, bullseye window or damage to the A-post of the vehicle, and that's basically if somebody's hit the windscreen. The pedestrian is that thrown over the vehicle, i.e. they went right over it, or they've been ejected from the vehicle at speed, i.e. this guy had the fence post, he was ejected from the vehicle at speed. Being unrestrained, and these are some special circumstances. So all these basically are vital signs, anatomy, mechanism. If there's yes to that, they go to an MTC, which is a major trauma centre. So they may well bypass the nearest hospital and go straight to a major trauma centre, given their mechanism of injury. How are we supported? Well, there's my unit right in the middle of here. We have helicopter, what they call the helicopter emergency ambulance services, 16 of them covering the whole of the UK. Response time, 17 minutes to anywhere in the UK, and a transfer time of 10 minutes. Where I have, there are 3 helicopters based at Blackpool and Barton. Barton's another airfield not far from where we are. And they cover the northwest, basically, which is our hospital, along with the hospitals in Manchester and Liverpool. They cover 365, 7 days a week. They only fly during daylight hours, unfortunately not during nighttime. They have a pilot, paramedic and a doctor on board, so they can provide pre-hospital care, basically. That's a view at my window in my office at the Royal Preston Hospital. It's the other day, it flies right over my office, which gets very loud, and that's our landing pad there. So is it beneficial? Well, a lot of studies looked here, and it's expensive running these service. It's about £850,000 plus to run the service using the ground rather than the ground one there. It does show that there is a benefit to doing that in the way of amount of patients saved, basically, rather than comparing it with road traffic accident. But it's an expensive mode of delivery of patient to you, but it gets them there quickly. So what about, I'm just going to finish on the last couple of minutes. Apologies for running over. Major incident mass casualty events. You'll probably all be aware of the major incident, what we call mass casualty events. In this day and age, most of it is terrorist related. You know, in India, I'm cognizant of the Mumbai incident you had. In the UK, I don't know if you remember this. This was in 2017. This happened in the northwest of England, where I am, and this was an Ariana Grande concert, which was held in Manchester at the Manchester Arena. Abdul Halehi, he detonated a shrapnel bomb, which was committed, obviously, suicide. And 19 people actually died immediately, but the total was 23 died. There was 112 people were hospitalised for injuries throughout the northwest of England. 27 were actually treated, which didn't require hospitalisation, but the majority, as you see, were children. It was a concert for children, and most of them there were teenagers, basically. And you can see that picture at the bottom. Most of them that died there were teenagers, or indeed the parents of the teenagers. So mass casualty and mass events are significant in this day and age, and we live with it. In the UK, we have guidelines. In 2020, they came out, basically, and it's quite a complicated algorithm, basically, but a lot of it revolves around primary triage at the scene and where they go to, which is either a major trauma centre, a trauma unit, or any healthcare facility. And then children on the right-hand side have a significant other one, basically. So initially, if it's a mass casualty, major trauma centre if they can. And then obviously, if the regional capacity has been exceeded, then we can look to transfer it out. And when this happened in the northwest of England, we had to alert our colleagues further afield in other major trauma centres, just in case we became overwhelmed with casualties. So this is how it happens when we have mass casualties. There you can see it's a very structured, very almost algorithmic, but very definitive protocols we've got for the patients, basically. We've got trauma anaesthetists, we've got rapid transfusers, the RT1 and 2. We've got a resus OPD, we've got 2 doctors, obviously, you've got the trauma team leader, and then you've got somebody who's just there to scribe. That's somebody just writing things down to see what's going on. And that's very, very important. And the trauma team leader coordinates everything there. So it's a very, very focused, very pragmatic way of dealing with major injuries. And this will be one trauma room, and you'll have another trauma room, which will have the very similar setup. So it's very, very structured in the way the care is delivered. From Maxillofacial, these are taken from the guidelines. Again, the guidelines are catastrophic hemorrhage, again, compression bandage, hemostats, silk sutures. Again, we can look if we have to damage the facial artery that's bleeding from there, about the superficial temporal artery. Talk about a loose maxilla. Again, we've talked about that as well. Blast injuries affect barotrauma, which affect the ear as well. So we've got to be mindful of that. Again, be mindful of obstructions from missing teeth as well. Head and neck wounds, again, we should explore them in theatre. Again, if it's a blast injury, you've got a lot of grit and foreign materials in there, you need to clean it out. Nasal hemorrhage, they talk about rapid rhino packing and posterior nasal packing. So it's very structured how we deal with mass casualties. And unfortunately, it's just one of these things in this day and age that maxillofacial surgeons will get involved in. And we were involved in some of the casualties that came from the Ariana Grande concert in Manchester, and they were children, unfortunately, which is even more distressing to deal with, rather than it's distressing anyway, but adults. So a significant wake-up call, really. And as I say, it can happen. If it can happen here, it can happen anywhere in the world. Just a little bit about some of the injuries. We've got to think about globe perforation, about the ears, about tympanic rupture, if it's thing about CSF, we've talked about the displaced maxilla, again, we talked about comminuted mandible. Teeth, are they on the floor, in the lip, or in the lungs? We've talked about that. Again, facial lacerations and stuff like that. We talked about penetrating neck injuries into the different zones and whether or not we need to always explore. Deep to the platysma should always be explored in the theatre. You should not be exploring that anywhere at all in the ER or indeed in your clinic. Take them to theatre. You never know what you might find. So that's been a sort of tour de force really of maxillofacial trauma in the golden hour of where we are. I've touched a little bit on some of the injuries that will be pertinent within that first significant period of what we call primary survey. Talked a little bit about what major trauma centres are and how we manage trauma in the UK. I know it's done differently throughout the world, and a little bit about mass casualties and how we deal with that again in the UK, given that we do live in these times, unfortunately. So again, just to say thank you very much to everybody. Obviously delighted to take questions at the end or whenever. So back to you, Jimson. Thank you.
Thank you, Prof. Thank you, Prof, for a well enriching and informative lecture. In fact, we are very happy that still we are following the GCS. Thank you for giving us that one. And there are a few questions from our participants. This is Srigant Vanjari. How to secure cervical spine if cervical collar is not available while transporting the patient to trauma center?
A simple way you can do it, there's no C-spine collar, it's just to use blocks, what they call block the neck. Now you can block the neck with anything there, basically. You can roll up cloth, or you can roll up some trousers, block them at the side of the neck and tape over the top of the neck, the head. So you can block off the neck there, anything to support the side of the head, and put some tape over it, basically. So you don't need to have a C-spine collar. Bizarrely enough, my car in the boot, I have 3 C-spine collars. I just, I carry them around with me all the time, basically, and one pediatric one as well. So there are ways that you can secure the C-spine, basically. But anytime that you see a patient, that you should be doing is keep hold of the neck and hold the neck and immobilize the neck if you're a first responder and you're on site, and you can use quite anything you've got around just to hold the head in what they call a neutral position.
Thank you, Prof. There is one more question. It's about securing the airway. In an avulsive injury, which is the better method to secure the airway, whether going for a trachea or a retrograde?
Depends which scenario you're in. I mean, if it's the emergency scenario, you need to get an airway in. An airway just means any airway you can get in. It has to be a definitive airway. A surgical airway, a tracheostomy, in my books, is not done as an emergency procedure. It can be done as a control procedure. And again, if you can do it in a control procedure, then absolutely fine. It's a very safe and secure airway, particularly if the patient is going to be significantly ventilated or requiring transfer to a CCU and is going to need a lot of ventilatory and physiological support. And then a tracheostomy, if it's going to be long-term, is much better than, for example, an oral tracheal tube, which comes with a whole load of issues. And we occasionally get asked, if a patient has significant panfacial fractures and indeed polytrauma, we wouldn't mind doing a tracheostomy at the time, which is fine. It adds half an hour onto your operating time.
Thank you, Prof. One more question we can take. Which is the best method to control hemorrhage in doing anterior and posterior nasal packing, out of pressure packing, or Foley's catheter, embolization out of all?
Embolization I wouldn't go for first of all. Finally, just use packing. That will control hemorrhage in about 80-90% of the time, basically. Put an anterior and posterior nasal packs. A Foley catheter is dead easy to put in along the floor of the nose and then just inflate it. So these are probably the easiest ones to do, and you will probably find that significant amount of hemorrhage will be controlled just simply by doing these simple methods. Embolization I would only use if we'd fail to do fail packing, basically.
Thank you, Prof. Thank you for sparing your precious time, especially on a Sunday morning. Thank you.
Oh, pleasure.
Next we have a lecture by Professor Veerababu sir. It is on management of hemorrhage control in general dental practice, which is the most common topic preferred and requested by the general practitioners, the students, undergraduates, the trainees, everyone. Even for the senior practitioners also, sometimes bleeding, hemostasis, controlling bleeding is a nightmare, or it gives sleepless nights for us, whether it is because of iatrogenic causes or bleeding disorder due to bleeding disorders or whatever it is, or intraoperative or postoperative, immediate or delayed, always the hemorrhage is a problem for us. Okay, so now we call upon Professor M. Meerababu sir, my teacher, to deliver his lecture on management of hemorrhage control in general dental practice. Sir, the screen is yours.
GPK, I have a bit of problem in sharing my screen.
Okay,
just
sir.
give me a second.
Yeah, take your time, sir. Take your time. So, meanwhile, Prof. Andy, the question for you, Prof. So, in a multidisciplinary approach, especially during golden hour, a patient comes to you with severe head injury, with neural problems, orbital problems, everything. So, how is the approach? Always the we say the maxillofacial trauma is not an emergency. So, how to deal with this type of cases?
Yeah, I mean,
can you see my presentation?
See it now, yeah.
Yes, yes, sir. We can see your screen. So I can take the question to Prof. Andy.
Yeah. Sorry for the interruption, Professor Andy. I had a little glitch.
That's all right. No problem, very good. I mean, you're absolutely right. I mean, we are low down a lot of panfacial fractures, we will fix 3 or 4 days down the line. There's no immediate rush to go in there. You're absolutely right. So we would often wait, particularly things like orbital trauma, zygoma trauma. We know that. Mandibular trauma is slightly different, but we follow the ATLS protocol, which is establishing a secure airway, dealing with any bleeding, restoring the circulation, dealing with any disability, making sure the patient's stable, first of all, because there's no point in having a dead patient, because you can't fix the facial fractures on, basically. So from our viewpoint, it would be a case of, and we're very much guided by our neurosurgical colleagues as well. We'll often delay surgery and stuff. So it's unusual for us to go ahead and deal with things primarily, basically. And it's often very difficult as well with the amount of swelling.
Okay, Prof. How late we can do maxillofacial trauma management?
Oh, I fix fractures 2, 3 weeks, 3, 4 weeks sometimes down. It becomes more difficult, as you know. Everything starts to heal very quickly in the head and neck region, but I have managed to fix facial. Orbital trauma, well, oh God, a year, I think, is the latest I've tried to fix, but it's been a healed fracture. So it's a post-traumatic injury then. So it becomes that grey area between trauma and then it becomes a post-traumatic injury, if you know what I mean, basically. So, anything within 3 or 4 weeks is okay. But after that, it becomes very, very difficult. And then you're dealing with a post-traumatic injury or a post-traumatic deformity. And that's a whole different talk.
Thank you so much, Prof. So now Prof. Veerababu sir can take the screen.
Thank you, Dr. GPK. Am I audible?
Yes, sir. Yeah.
Yes, sir. Thank you, Dr. Jim, Dr. Reena, Dr. GPK, and the Tamil Nadu State Branch, as well as the University of Masha, Vinayaga Mission, and Tahur for giving me this wonderful invite and opportunity. And I was told by Mr. G. Padmanabha Kumar, and I fondly call him GPK. Now, is Dr. G. Padmanabha Kumar told me that, sir, make a presentation keeping in mind of the undergraduate and the general practitioner who has asked for this topic. So after listening to that massive hemorrhage from Professor Edward, you are going to see that nagging dental bleeding from the oral cavity and how to manage it. See, either you are a dental surgeon who was doing a general dental practice, or you are doing any of this specialty. If you're not doing an exclusive specialty practice, if you're going to do some of the oral surgical practice, what are the oral surgical practice you will be doing? Extractions, open methods, if the tooth breaks or somebody comes with a broken tooth, or root. Minor impaction, that is fully erupted wisdom teeth, which you think that you need not send it to a specialist and you want to remove it. And periapical surgeries, at least in the anteriors, and small biopsies. These are the procedures a general dental practitioner will be doing in his practice, if he's not referring to an oral surgeon. In our kind of practice in India, with a massive population of 130 crores, not all the patients will be coming to the specialist. The general dental practitioner is expected to do attend these kind of cases. I'm sure even in Malaysia, all these patients will not be having access to the specialist. And some of you or most of you or few of you will be dealing these cases. So you should know when you get hemorrhage at the time of extractions, or open methods, or minor impactions, or periapical surgeries, or biopsies, what is the protocol or procedures, or algorithm you are going to do to control the hemorrhage. Nobody is going to die of these hemorrhages like these maxillofacial massive casualties and injuries, but these things are very nagging, and unless you do properly and control, the patient is not going to be your patient after this procedure. Why it is more, hemorrhage is more common in the oral procedure is it's highly vascular. I know, got both sides carotid supplying the face. So it's highly vascular. That is one reason all our extractions heal very well. For information, each extraction is in a compound fracture. If it causes the same kind of injury in the femur, it will become an osteomyelitis. Evolutionally, we have developed some resistance, and also due to this high blood supply from both the carotids, our wounds heal very well. But unfortunately, because of the extreme blood supply and an open wound, see, every extraction is an open wound. That is the actual source of the bleeding is open to the oral cavity. And you can't put a pressure dressing like in other part of the body where if there's a bleeding in your hand or anything, you can put a pressure with a big pack, a gauze or something like that. But here you can't put the pressure pack regularly. And tongue is in another organ which will keep disturbing the already formed clot, and you have salivary enzymes which may lyse the clot later. So these are the reasons for bleeding after extractions. What are the usual situations you will see after extraction? Immediately after the extraction, you are a dentist, you have done the extraction, and the bleeding is not stopping. That is a kind of, we call it primary hemorrhage. You have done the extraction, the bleeding is stopped, the clotting is formed. In the night after 24 hours, in the night, he calls you saying that doctor had developed a bleed. That is third situation where after 24 hours, within 7 days, they call you that they are having another bleed. In all these three situations can happen to your patient, or it can happen to somebody else's patients. That is, if you have done the patient and they start bleeding and they come to you, you are more emotionally charged, you may not follow all the signs. But if somebody else's patients, you are more daring and you will follow all the protocol. This is what we have seen. But if you follow the protocol, which I am going to say, whether it's your patients or other patient, you will be able to manage better. Bleeding could be due to local and systemic, and I am going to tell you only about the reasons, local reasons. The systemic is entirely a different lecture. So every patient, before you start the extraction, you have to ask, have they undergone previous extraction? In the previous extraction, have they had any bleeding episode? That is a very important question. If they say that no, we have not undergone any previous extraction, ask them whether they have undergone any previous surgery like appendix, hernia, tonsillectomy. If they say they have not had any previous extraction, they have not had a previous surgery, the third question is, have they had any previous accident? They had a fall from a cycle, they had any suturing on the chin, or any cut with a knife or a blade. Was there any bleeding? Because there's a very significant question. If they say that they had a torrential bleed, then it will give you an idea that they may be having some systemic problem. You may also ask some family history, because if the family history has got some other bleeding diathesis or disorder, then you should be more careful. These are the 4 questions you should ask before starting your extraction. What are the 5 medication history you will ask? 5 A's, I call it. The patient is on aspirin, that is called antiplatelets, any newer or old generation antiplatelets, anticoagulants, any old generation or newer generation anticoagulants. Are they on long-term antibiotics which can disturb the vitamin K formation? Are they on long-term, there is a chronic alcoholic which can cause some hepatic disorder or cirrhosis? Are they on anti-cancer, which is an anti-metabolites and can cause some platelet issues? If they are on all these 5, any one of these 5 tablets or any one of the 5 drugs, you should be more careful. You should assess the patient for bleeding and clotting protocol. Tests should be done for them. Systemic diseases, the hepatitis and hypertension should be ruled out, because if there is a liver issues, you know, factor 2, 7, 9, 10 will be affected. There can be prolonged clotting time and prothrombin time. So we need to evaluate it. Hypertension in my practice it's around 160 by systole by 100. We usually do the procedures. More than that, we refer to the practitioners, get it controlled, and we do it. Most of the time, people say that the bleeding is due to hypertension. Hypertension is not a major issue when it comes to bleeding. They're more worried about the stroke and cardiac issues. We can manage hypertension and we can go ahead with extraction. So normally after extraction, how do you proceed? You place a 2 into 2 inch gauze, ask him to bite tightly for half an hour. Do not take it, because every 10 minutes you try to take it, the ooze will come and then you will think that the bleeding has not stopped. You should give enough time. Ask him to bite for at least 15 minutes, take it out, then place a new gauze, give a good post-operative instruction and send them. When you place your gauze in the extraction socket, you should see that, because I told you you cannot put a pressure packing, you should see to that when they bite, that gauze goes in between the two sockets and compress the socket and controls the bleeding from the gingiva so that the bleeding stops. In orthodontic cases, in between the wires, sometimes they are not able to put the gauze. So most of the patients, they come back with the bleeding. All we do is change the old gauze, put the gauze in between the socket, go all the way up to the socket, the bleeding stops. So what is very important here is atraumatic surgery. That is the gentle elevation of gingiva and not crushing like an alveolar purchase, crushing the gingiva or the bone. And after extraction, if there are any bony spicules, gently remove the bony spicules, because these things are reason for the post-operative bleeding. Usually bleeding is from the soft tissue and the hard tissue. So how do you know that it is coming from the soft tissue or the hard tissue? So if you just compress the socket tightly for 10 minutes, after 10 minutes you leave it. If there is no bleeding, then that is coming from the granulation tissue around the socket, that is from the soft tissue. And even when you are compressing, the bleeding is coming from the socket, then there is bleeding is coming from inside the bone, from any of the nutrient canals or the inferior vessel, which need a different kind of management, which is not just going to stop with the soft tissue suturing. Most of the time, the soft tissue bleeding, what we have seen in a practice is granulation tissue. All these chronic destructive periodontitis cases with the granulation tissue or periapical granuloma, after you extract the tooth, when you leave the granuloma, which is rich in vasculature, they start bleeding. What you do is you put the gauze, ask him to tightly bite it, and after half an hour or 15 minutes, you take it, you still see the blood coming. What you are missing is you have not removed the granulation tissue. So you nicely curate the socket, you remove the granulation tissue. You got various forceps like Alice tissue holding forceps, mosquito artery forceps, and curettes are there, which will beautifully curate out this granulation tissue, which will immediately stop the bleeding. But a word of caution is when you are removing the granulation tissue, 2 areas you should be very careful. One in the upper 6 or premolar or 7 region, where when you are curating the granulation tissue, you should not enter into the maxillary sinus. So one should be very careful and gentle in removing at the roof of the tooth of the 6 or 7 or 8. And also in the lower region, in the 6, 7, 8 region, after the extraction, you compress the socket for 10 minutes. Bleeding is not stopped. You think it is coming from inside the socket. If you want to curate the socket, thinking that there is a granulation tissue, when a granulation tissue, when a curating it, you should be very careful, because sometimes if there's a thin bone between the inferior alveolar canal and that granuloma, you may go and injure the inferior alveolar nerve, which may result in numbness and patient will be unhappy. So you need to be gentle in that inferior alveolar canal region also. If necessary, you can put a gauze pack, take an IOP or OPG, check the distance between the root end and the nerve canal. If there's enough distance, you can aggressively curate it. If there is very less distance, you have to be very careful in removing the granulation tissue. Most of the time, the post-operative bleeding, which we see in our casualty, they stop with this pressure pack or removal of the granulation tissue and a gentle suturing. So soft tissue bleeding, I said, you just compress it, the bleeding stops, it comes from the soft tissue, just suture it. Pressure and suture will take care. Nowadays, you've got a radio frequency diathermy, electrocautery, small gingival bleed can be stopped. And these are the instruments used, which I have shown in the pictures. There are other agents which can help you control the bleeding like Surgicel and gel foam and bone wax. See, when will you use Surgicel and gel foam? When will you use a bone wax? See, I told you the soft tissue bleeding and the hard tissue bleeding. In the soft tissue bleeding, you can use after compressing the socket, after removing the granulation tissue. If you still think that it is coming from the soft tissue, you can pack the socket with the Surgicel or a gel foam, or nowadays we get microfibrillaർ collagen like Avicene. This is what commonly we use. We pack the socket and we do a figure of 8 suturing or a horizontal matter suturing like this. Just place a suture like this, put a Surgicel which trap all the platelets and forms an artificial clot. And this beautifully forms a clot like this. So I would advise all the general practitioners keep at least one herb gel or gel foam or this kind of a Surgicel, which I love to use it. And bone wax is an absolute must if you are doing bone surgery near the third molar area. And that's the doing near the premolar region, the mental nerve region. If there are some bony bleeding, you can use a bone wax and control. Bone wax is kind of a wax-like thing. If there's a bony bleeder from the nutrient canals, or if the bony bleeding from the inferior canal from the small part, where you cannot go and use your cautery or a diathermy because it will become a numb, pack the socket with bone wax, the bleeding stops. So reactionary hemorrhage, which is what I was telling you, they come to you after 24 hours. Usually check the BP. If the BP is high, try to reduce the systolic pressure. Don't get panic. Position the patient, suction the socket. You need a good illumination to know whether it is coming from the soft hard tissue. Don't do anything. Pack it for 5 to 10 minutes. Wait. Most important is this 5 P's: pressure, pack, position, and patience. That is, the pressure should be for 10 to 15 minutes. Most often I see the young residents keep taking that gauze and keep saying that, sir, the bleeding has not stopped. The problem is you are not allowing the natural mechanism to form the clot. So you should give enough time for it to clot. So 10 to 15, nobody is going to die of a bleeding from a dental socket after an extraction. So you be patient, you wait for 10 to 15 minutes, the clot will form. And the pack, as I told you, should be adequately packed into the socket so it goes to the root of the area where the bleeding is starting. Position, keep it in the head down position. Don't go, keep it in the head up position. And you wait, give the sufficient time. And even then it just doesn't stop, start praying. And this is the bottle section. And I see the general practitioners are using the dental suction tip which is used for the restorative work. I am telling you, if you have this kind of a separate bottle section, it's a nice thin stainless steel suction tips. You are able to, with a thin number 3 or number 4, you can go to the source of the bleeding and you know exactly the bleeding is coming, and you can decide whether you have to put Surgicel or gel foam or the bone wax, or you have to use thrombin, you have to use bipolar, radio frequency cautery. How do you decide? You should know where the bleeding is coming. To see where the bleeding is coming, you need something which is so small, which go into the area. If you use the other one, the dental plastic tip, you will not be able to find out where the bleeding is starting. And this is the ab gel I'm just showing you. This is a gel foam. It absorbs the bloods, expands in size, and compresses the bleeding spots, and that produces the clot. You can put a figure of a suture like this. See, I am showing in a non-bleeding case for the sake of demonstration, because when there is an actual hemorrhage coming into a casualty, patient doesn't allow us to take a picture. There the situation won't be as rosy as like this. The patient will have blood around the corner of the mouth, face, his shirt. So you are a young dentist. You should not panic, because of one funny incident, one of the patients told me that he went to the patient's doctor's house and knocked the door. As soon as the dentist opened the door, he saw the patient with all the blood on his shirt and everything, and he fainted. So the patient always recalled, sir, I have to take the patient doctor to the casualty, and both of us went there and got treated. So do not panic, do not get tensed. Following these measures, you can easily control the bleeding, because it is not the major maxillofacial massive hemorrhage from the maxillary artery, which Professor Edward showed in his cases. These are coming from the dental socket, and you will be able to manage if you follow the standard protocol. A lot of the local agent, which I already told you, gel foam, Surgicel, collagen. So of course, some of us use the thrombin. By using this thing, we can control the primary and reactionary hemorrhage. That is one which is not stopping immediately even after extracting it. This reactionary hemorrhage is they go home, they knock your door in the night after 24 hours or 12 hours. Secondary hemorrhage, the patient is absolutely fine for some time and they call you on third or fourth day because of infection or some other disturbance, the clot gets lysed and they come to you with the bleeding. You know that it is mostly due to the infection or disturbance of the clot. So give a nice block, anesthetize the patient nicely so that the blood pressure comes down, they don't have the pain, they're comfortable. Curate the area if the old clot and the gold granulation tissue. Put size Surgicel, which is my favorite. You can put gel foam, put a nice figure of a sutures, put a pack, and start them on antibiotics. Become alert when you see somebody with a lot of bleeding coming out of the mouth after the extraction, after 3 days or 4 days, they come to you. Keep everything ready, but don't panic, because when you panic, your mind doesn't work, then you don't know what to do. You need to observe the patient also as a whole. Imagine this patient came to us last month and they were trying to do a lower wisdom tooth 8. One of the intern was doing. I went and told her, see, look at the lip. What is that? She didn't know what it is. It's a small AV malformation. And if you by accidentally injure that area, the control of bleeding is going to be difficult. And your extraction should be very careful. And we told her, put a cheek retractor, ask the assistant to keep this area away from the injury, and we gently remove the tooth. So when you are examining the area near the tooth, around the tooth, the tongue, you have to look for all these things, because sometimes we get a patient in the casualty. Once we got they tried to remove a lower wisdom tooth, and unfortunately it turned out to be a case of AV malformation, and we need to ship the patient for selective embolization to control the bleeding. But that is one unfortunate event, but which could not have been found. When you took an OPG, we saw a huge AV malformation, which the attending dentist missed it. So, but you should know that when a bleeding is massive and is not getting controlled with the standard protocol or algorithm, which I told you now, then you should think of something sinister, should call the maxillofacial surgeon or any other specialist who is involved in major surgical procedure. You should not waste time, ship the patient and control the hemorrhage. Because of ego, you should not be wasting too much time. And by the time you go to the clinic or hospital, they should not say you come too late. And there's some surgical anatomy. When you're trying to do open methods, when you're trying to make a vertical incision like this, at the lower end of the thing, theoretically speaking, you can injure the facial artery, which is coming and taking a turn here. So when you are making the vertical incision for a wisdom tooth or a third molar, it should not go too much into the soft tissue, and you should not be too rough in that area. Very rarely, you might nick one wall of the facial artery. The bleeding will be difficult to control. You may have to get access from extraoral. So this is the region. I hope you can see my arrow. You have to be careful. And in this IOPA, you can see these two lines. That's lines showing the canals, the inferior alveolar canal, that very close to the root of the third molar. Imagine if this teeth breaks here and you're trying to split and take these two roots, you should be aware that if you are using a fine micromotor with the 701 or 703 burr, not everybody is fortunate to have piezo, which will not injure the vessel, they say. They claim at least. If you are using a nice tungsten copper bar, rotating bar, if you are not careful that at what depth you are going, you may nick this inferior alveolar nerve, and that may cause a bleeding, which may need a bone wax to control. But remember, if you removed the tooth, then it is easy to put a bone wax and control the bleeding. But you have nicked this inferior alveolar canal. Before removing the tooth, you will find it difficult to put the bone wax. Sometimes we put the bone wax, close the socket, and after 7 days, we go back and remove the tooth. So you should, whenever there is 8 region, the tooth is fractured, don't start your open method or surgical removal. Go take the X-ray, check where the inferior alveolar canal, or is there any pathology around the 8, then proceed with the case. Because sometimes in the clinical practice, You attempt 8 with without X-ray. It fractures, you start proceeding it and getting into trouble. Do not do that mistake. Always take the X-ray and start proceeding. And this is just a soft tissue thing. If you're taking a biopsy with a simple interrupted suture, you can get a good bleeding control. If you are doing any surgery on the palatal side, there's a huge cyst, nasopalatal cyst, one of my colleagues is removing it. You should need to say that there is an artery coming here, it's called nasopalatal artery. Sometimes if you are removing, sometimes if you are removing this periapical cyst on the palatal side, you need to understand that you might have to catch the nasopalatal artery with a clamp, cut it, cauterize it, and then you can remove the cyst. But suppose if you accidentally cut the nasopalatal artery, nothing is going to happen. Take your mosquito artery forceps, catch it and crush it, or use a bipolar and cauterize it. If you don't have access to bipolar or the monopolar, all you have to do is put a nice pressure on that foramen, or put the palatal tissue back on the palate and compress it for 10 minutes. The bleeding will stop, and take a intrapapillary suture to the labial papilla, the bleeding will stop. Remember, pressure pack position patients, even if you can't control, just hold on to the bleeding site with a pack. We even say to the postgraduates, if they can't control the bleeding, just hold on to it and call for help. As long as your pressure is there, even on the carotids, the bleeding will stop. The panic, we try to do something else, then we are not able to control the bleeding. It is the pressure pack position patients which is very important in controlling hemorrhage, whether it's a maxillofacial hemorrhage or the dental hemorrhage. Of course, as I told you, diabetic patients or immunocompromised patients, they have got most of the time they have got chronic destructive periodontitis cases, the granulation tissue. Those patients tend to bleed more. People say that diabetic patients tend to bleed more not because of the diabetic situation or hyperglycemia, because these patients, most of them in our part of the country, tend to have poor oral hygiene and chronic destructive periodontitis. The granulation tissue causes continuous bleeding, which I told you already that you cure the granulation tissue, the bleeding stops. And you need to be careful with the children and pregnant patient. You take extra precautions to avoid bleeding in these cases because they are special. The children with the low blood volume and pregnant patients with other systemic issues going on, it's difficult to position them and difficult to stress them. So in my opinion, take extra precautions and avoid bleeding in these patients. If there is a bleeding, follow the standard protocol, pressure pack position patients, and putting surgical gel foam, figure of 8 sutures will take care of the bleeding. Tuberosity fracture is one of the nagging one. When you are removing the upper 8 teeth, if you are putting the cryo elevator or whatever technique which in your part of the country and your unit they are teaching you, with a gentle pressure, the teeth is not moving. My advice to you is to do an open method and remove the upper 8 wisdom teeth. Most of the time people give a little brute force, they fracture the tuberosity, and we have had patients, people are removed 7 and 8 together with a massive hemorrhage, where we had to do a ECA ligation in one case because they tried to control the bleeding, they injured the maxillary artery, and patient has to be shifted to the general anesthesia to control the hemorrhage. Even with a pack, it was bleeding to the nose, and we had to get the carotid control, one rare case. So tuberosity fracture is quite common if you are not careful in the control of pressure in the removal of the upper 8. And if you're very careful, you will not cause problem. If it's a minor tuberosity fracture, dentally dissect it out and take it out, and the bleeding can be controlled with the pressure and a nice suture with a surgical or a gel foam. Inferior alveolar vessels, as I already told you, you can manage with bone wax. Do not put diathermy or cautery because the chances for numbness is there. Patient may not forgive you for a numbness when they come to you for a simple 8 extraction or 6 extraction. Sometimes you see these kind of fracture in the mandible, which like our Professor Edwards showed, the casualties, the cases come to you. Suppose if you are practicing in the peripheral village or away a town where a patient walks into practice with fallen from a cycle or a motorbike with an injury in the anterior region, all you have to do is just pass a wire around the teeth and tighten it, the bleeding will stop. I have been called sometime into major hospital by other specialists that they tried suturing, they put surgical gel foam, nothing stopped. I go around, put a wire around to tighten it and approximate the fragment, the bleeding stops. This, as a dental surgeon and oral surgeons and a maxillofacial surgeon, we should know approximation of the fractured fragment, the best way to stop a bleeding in the facial-maxillary trauma. Of course, maxillary fractures beautifully shown by Professor Edwards, like anterior nasal pack and posterior nasal pack. That is beyond the scope of a general dental practitioner. If you're a maxillofacial surgeon, already Professor has explained to you in detail anterior nasal, posterior nasal, and all the epitech catheters and the latest techniques there to control the anterior nasal bleeding and the posterior nasal bleeding. Simple dentoalveolar injuries and bleeding, as I told you, just reduce the dentoalveolar injury. Put the alveolus back into position, put an impression compound or the wire or your composite, reduce the fragment, suture the wound, the bleeding will stop. Most important thing, as if there are some students for the undergraduates, I do not advise posterior superior alveolar block. I do not know whether Dr. G. Padmanabha Kumar is advising it. Some of the units are advising this for posterior extraction, but the students go in and injure plexus and causes huge hematoma. I would always tell that just infiltrate near the upper 8 or 7 and extract, because the maxilla porous bone, you get good anesthesia and extraction. You need not go and do a posterior superior alveolar block for a simple extraction. And if you're not aspirating, if you're not twice aspirating, if you're not turning the syringe and aspirating, you may injure the plexus and it may pterygoid plexus, and that bleeding, it's not life-threatening or it is not nagging, but the whole cheek will swell, and the swelling will take some time. And if it is a very fair person, it changes his color over a period of 15 days, and they will keep calling you. So you need to be careful with these patients. There's another case. This guy, if I remember, had a Christmas disease or factor 9 deficiency, landed with us. For that time, we used some ferric chloride to control the bleeding. Then later he was sent to the hematologist, and factor 9 replacement was done to control his bleeding. So to conclude, I told you how to control the local measures: pressure, pack, position, patience, and prayer. I said gel foam, surgical, bone wax. With these 8, you can control intraoral hemorrhage. If you know figure of 8 suturing, vertical matter suturing, horizontal matter suturing, complete pressure, if you can maintain it, you can control hemorrhage. What patients systemic thing? Nowadays, we get 2 groups of patients, and different countries have got a different protocol and system. Either patient is on anticoagulation, like warfarin and coumadin, like old anticoagulant. Now the recent directly acting anticoagulants are also there. This patient comes to you for extraction. What they do a bridge therapy. What they do is they stop this anticoagulation medication and they substitute with the heparin, and 6 hours before they stop the heparin, they do the procedure. 6 hours they start, later they start, and they proceed. That is one way called bridge therapy. But if you stop this, some of the cardiologists or some of the general physician, I'm not sure, they just simply stop this medicine and they ask you to do the extraction. But the potential chance for them to develop another stroke or an attack is very high. So I wouldn't advise you to stop this anticoagulation medication if the INR, international normalized ratio, is maintained anywhere between 2 and 2.5. Up to that, there are all systemic reviews and studies published, and nice protocols are there. Nobody stops nowadays warfarin or coumadin for extraction or a simple extraction, non-complicated extraction, one-tooth extraction. If they are on multiple drugs, I would advise you to take a medical opinion. You need to discuss with their medical practitioner whether need to do a bridge therapy, or you can go ahead and put a gel foam and control the bleeding. So this is INR, patient's prothrombin time by lab prothrombin time. Normally it is 1. Up to 2.5 you can manage with gel foam, surgical, bone wax, or any one of the local agents to control the bleeding. Normally the bleeding stops by itself. The bleeding, clotting does not form. We can use any one of those measures which I taught you now. If the INR is up to more than 2.5, you need to discuss with the physician, because in my part of the country where we are not dually qualified, if there is an hemorrhage without consulting our physician, there are some medical legal issues. So we always take the consent and the opinion from the general practitioner. I'm sure Professor Edward and Professor Sambrook, with their dually qualified, with their board, they may be going ahead doing it. This is the protocol we are following here. What about the antiplatelets like aspirin? We don't stop it. The newer generation antiplatelets also we don't stop, because these things are not a major issue. The bleeding stops by itself. If it does not stop, we can always use a Surgicel and close it. It stops by itself. But if they are using multiple antiplatelets, if you use clopidogrel, if you use aspirin, along with that, if you use some of the anticoagulants for other atrial fibrillations or other disorders, then you need to discuss with the physician, titrate the patient, take all precautions, then you go ahead and extraction. But if you stop antiplatelets, that is the drugs, without consulting them for worrying about bleeding, they may end up having another stroke or another attack. In that case, the patient may question you. Then if there is a medical board, will say that why did you stop this potential drug? Because of this only he developed, because there are various reports nowadays telling their patients are more prone when you stop these antiplatelets. So you need to have a very clear discussion with the treating physician. If you are planning to stop these drugs for doing 3 or 4 extraction or whole quadrant implants, please discuss with your anesthetist or intensivist or a physician before taking up the case. So these are the anticoagulants and antiplatelet protocols we follow. Nowadays, because of this life expectancy is more, and you see elderly patients, we are trying to do everything in a day. And these medically compromised patients, if you are not well equipped, well prepared, well advised, you may land up in trouble. So follow the international protocol, follow the evidence-based science. You will come out in flying color with successful. So if you fail to prepare, so you're actually preparing yourself to fail. I'm sure that will not happen to you, because you are all an excellent under the hands of Dr. G. Padmanabha Kumar and excellent professors. So with this, I conclude my lecture. Thank you, Dr. GPK, for a wonderful opportunity. Thank you for listening.
Thank you so much. Once again, your lecture is so interesting and elaborate as usual, and very informative for the undergraduates and general practitioners. There are a few questions for you, sir.
Yeah.
How to pick up AV malformations and avoid procedures routinely?
See, these AV malformations, routinely, they are not going to come to you all. Once in a while, by inspection itself, you will see. The case which I showed you, you saw it in the lip. It's a venous malformation. You can, when you palpate itself, we know. So inspection and palpation and bruit and all these things will tell you, you compress it and leave it, it starts filling. Because hemangiomas comes in younger age, it resolves by itself, AV malformation persists. So this, if there's a central hemangioma, you may not be able to get it. So in that case, you need to take X-rays, routine X-rays for all these patients. But we are, I do not know about your protocol. In Malaysia, do you take routine intraoral periapical X-ray for all these cases?
No, sir. No, routine.
No, so routine cases, we can't pick it up. It's a fate of luck. We sometimes get cases, people extracted the tooth on this intraosseous AV malformation and we managed it. But if it's a soft tissue ones, by inspection itself, we can pick it up.
Yes, sir. So what is your opinion on patients on multiple oral anticoagulants? Yeah,
multiple oral anticoagulants, I will definitely refer to my physician, take the opinion of him. But only thing, I will put my thoughts to him. If he is not updated contemporary physician, sometimes I come across physicians who are not keeping update with the latest protocol, and they will tell stop this, stop that. So we need to be confident of the person whom we are referring. And if there are multiple things, I would like to go for a bridge therapy, which I told you. I will stop 3 days before. They give heparin. They stop 6 hours before. Then we stop it, do the procedures, start again, and slowly replace it with your anticoagulants.
So one question from one of the student.
Yeah.
My patient had a hemorrhage from 2/6 extracted site throughout the night.
Yeah.
So what could be the reason how to handle this case?
Actually, I should not be giving the reason because I have not seen your patient. That is not correct. I can imagine various reasons. See, first of all, have you taken the history? if the history does not have, see, if the patient is not a hemophilia, if patient is not an Van Willebrand disease, patient is not having any Christmas disease, there is not a thrombocytopenia, any one of the medical problem, then you know there is no systemic causes. If they are not taking any medication, it is not due to drug. If it is a healthy patient whom you have done the extraction, then what does that mean? You have not compressed the socket, you have not controlled the bleeding from the gingiva, you have not put the pressure pack properly. One, or you have done everything, he has taken it, he has dislodged the clot with his tongue, and there is some bone spicule, there could be some granulation tissue. We don't know. We have to inspect the case, or the person who attended the case only can give the reason. What I am telling you are multiple possible reasons. Local and systemic. You rule out systemic first. The local, soft tissue and hard tissue. Compress the socket, bleeding stop, soft tissue. Suturing will take care. Even after compressing, it does not stop. It is coming from the socket. Look for granulation tissue. Even after removing granulation tissue, if it doesn't stop, look for nutrient vessels or some other vessels which can be controlled with the bone wax and suturing. But all this time, the BP should be monitored, a drug history should be taken, that the family history to be taken for other bleeding disorder. I had a case where everything was done, sent to the hematologist, and he gave a clearance because the patient gave a history of bleeding from his palm after he did the expedition to some hill or something. What happens 14 days later, he developed a bleeding, he told me. So I did all bleeding and clotting tests, referred to a hematologist. Post-operatively, after I removed the 8, third day he started bleeding. We didn't know, every test is normal, taken this thing. Then he was referred to a hematologist. That time he told it could be a mild hemophilia because during the stress level, these patients start bleeding. So when they gave factor 8 assay, the bleeding stopped. The patient's parents did not tell the patient himself that it's a case of mild hemophilia. Otherwise, the patient was a perfect patient. On that day only, the patient came to know that he is a mild hemophilic patient. This is a peculiar case I had in my practice.
Thank you, sir. Can IOP give any definitive signs of AV malformations?
No, I don't think you can't.
Okay. Thank you, sir. Actually, here we have a strict protocol, sir, because of medical legal issues. If any patient gives any history of traumatic extractions or any history of bleeding disorders or any other bleeding problems, then we refer the patient to the physician or to the hematologist. We get the written expert opinion. Based upon their opinion, we touch the patient. We decide whether to proceed or not.
Okay. So this medical opinion is given by your medical colleague, if I am correct.
Yes, sir. Yes, sir.
Okay. Yeah, that's the same here also. But we are the only thing I would be very this thing is I should have confidence in my physician whether he is following the standard international protocol.
Usually, the patients on long-term blood thinners will have a note with them, detailed report with them. And based upon that, we proceed, sir.
Okay.
Thank you, sir. Thank you.
Thank you. Thank you.
For a wonderful lecture. Have a great evening, sir. Thank you.
Thank you. Thank you. Thank you. Thank you.
Thank you, sir. So now. So
thank you, Doctor. Yeah. Dr. GPK. Yeah, thank you, Dr. GPK, for that moderation and those wonderful lectures that we heard from Professor Andy and Professor Veerabao. I think there's one question to Dr. Veerabao about if there is any recent article regarding systemic causes for bleeding from extraction socket. Is there anything like that you want to add on, Dr. Veerabao?
No, I'm not sure what recent article you are putting.
Okay.
But
So I think, yeah, recent guidelines for systemic causes. That's what they've asked.
Yeah, see, basically you are going to see if the patient, you are going to take the history. If it's an young patient, if there is no systemic problem, what is that to worry? If they give a family history of hemophilia, family history of if the patient is having some other bleeding problem or issue, then you take the history.
Yes.
Then you do bleeding time, clotting time, prothrombin time, partial thrombin time, platelet counts, and you do INR on all those profiles. Then take an hematologist's opinion. Then you proceed with that.
Yes, Dr. Veerabal, we got that very clear. A detailed case history is very important, and then
important.
following it up with a proper observation of the patient, and then relevant investigations and proper inference of the investigations.
Yeah.
And then I think that's the protocol you're
Family
talking about.
history is what sometimes
Yes.
they are missing it.
Yes, Dr. Veerabal. Thank you so much for that answer. So we move on further for the next lecture by Professor Dr. Sambrook, who's going to talk to us on management of potentially malignant disorders. So from bleeding, we are going on to potentially malignant disorders. Professor Sambrook.
Sorry, I had a little bit of trouble getting myself off mute. Thank you very much for the opportunity to talk. And on this St. Valentine's Day, I wish all the panelists and attendees the peace and love that the world can bring. So we'll move on to potentially malignant disorders here. As you know, there's been quite a lot of change in terminology and in this area where we used to have pre-malignant lesions, pre-malignant conditions, and the World Health Organization and many other researchers have grappled with these sorts of issues. So we're going to have a look a little bit about assessment, the risk factors, the carcinogenesis, the way things progress into cancer. And this should dovetail very nicely into Professor Vijay's talk coming up next. So we'll talk about some anatomy and some subsites, a little tiny bit on epidemiology, and then on to risk factors, the pathogenesis, and then, of course, some potentially malignant conditions. And I certainly don't intend to have a talk about extensive lists of pre-malignant conditions and go through each of them individually, but we will talk a little bit about the more philosophical basis of malignancy. As we all know, head and neck cancer is more common in several regions of the world, and the oral cavity, including the tongue, is most common in the Indian subcontinent. Nasopharyngeal, more common in Southeast Asia, and pharyngeal and or laryngeal more common in other populations, but we're not going to talk about those particular conditions here. It is suggested that there's about 650,000 cases worldwide and over 300,000 deaths. And in the past, males were affected significantly more than females, although these figures are getting a little bit closer together, simply because of the change in risk factors and also the change of pre-malignancy and cancerogenesis. Primary risk factors, as we all know, tobacco use and alcohol consumption, and HPV is more significant in oropharyngeal cancer rather than oral cancer, but we'll talk a little bit about that. And of course, the Epstein-Barr virus in nasopharyngeal cancer. I don't want to go through too much of this, but the boundaries of the oral cavity are as suggested here. And there are some subsites within the oral cavity that perhaps have different ways that they behave. This is according to the American Joint Committee on Cancer. So the subsites being the lips, the buccal mucosa, the oral part of the tongue, the anterior 2/3, the floor of mouth, maxilla, alveolar ridge, and retromolar trigone, and may have different behaviors and may require some different treatments, although ultimately the treatment may well be the same for a lot of these. In Australia, where I'm from, just to give you a little bit of a flavour, oral cancer accounts for roughly 5% of all cancers in Australia, and we have a very high incidence of melanoma, particularly in some of our northern climates. And in some areas, oral cancer accounts for 8 to 10% of all cancers. We have an incidence of 5 to 10 per 100,000 per year, with a mortality of 2 to 3 per 100,000. Again, this male predilection in Australia is about 3 to 1. And the risk of oral cancer does increase with age, although we are now seeing a very much larger increase in patients with younger cancers. And we're now seeing quite a number of people in their 20s and 30s that we weren't seeing, perhaps 20 or 30 years ago. Squamous cell carcinoma represents the vast majority of what we're talking about here. Conventional squamous cell carcinoma, about 90%. I would put some of these subtypes as really falling into a conventional subtype, particularly verrucous carcinoma. And it's sometimes easy to think of verrucous carcinoma as maybe not so severe or easier to treat, but clearly it's a conventional squamous cell that is a little bit more exophytic than endophytic. But the others, the spindle cell carcinomas, papillary squamous cell carcinomas, basaloid, and the others there can behave a little bit differently. The other malignancies that generally are not involved in the pre-malignant conditions include sarcomas, salivary gland tumours, mucosal melanoma, very unusual disease. Usually when it occurs in the oral cavity, it is very difficult to treat and often has a poor prognosis. And then lymphoma and metastatic diseases. Okay, so let's move on to to what we're actually talking about today, and that is these conditions. So the risk factors in oral squamous cell carcinoma: smoking, definitely, and the heavier you smoke, the greater the risk. If you start smoking at age 12, 13 or 14, which many people did 30 or 40 years ago, then the risk is higher, and also the duration, particularly those who have been smoking more than 30, 35 years. In our institution, for a long time, 95% of individuals with oral cancer had a smoking history. As I said, that is changing somewhat now, and some of the more recent figures show a lower rate of smoking in some of our cancers. People think that maybe chewing non-smoking tobaccos may be a little bit better, but they have an associated risk of oral cancer. And it's the nitrosamines and the carcinogens, the nitrosomonornicotine, and the other carcinogenic agents that are in the tobacco that actually cause the change to cancer. So it's not just the smoke itself or the heat. And alcohol consumption by itself is an independent risk factor, but it also is a promoter and has a multiplier effect and a synergistic effect with tobacco. And heavy drinkers and heavy smokers have greater than 20 times the risk of squamous cell carcinoma. Betel nut chewing, or the betel quid, I should really say, the areca nut, increases risk by about 8 times. And again, if people chew the betel quid and smoke, then the risk can be up to 123 times greater than without either of those two factors. And the betel quid is also involved in other cancers also. HPV is where a lot of research is coming through. As I've suggested, HPV is not necessarily associated so highly with oral cancer, but is certainly associated with oropharyngeal cancer at about 45 to 67%. These tend to be the younger, non-tobacco, non-alcohol users, and also very much more a more equal sex distribution than the tobacco and alcohol ones. Unfortunately, early lymph node metastases occur in HPV-associated cancers, and HPV 16 and 18 are associated with the oral cancer. Other infections, Epstein-Barr virus, HSV, HCV, can also be associated with oral cancer. And chronic hyperplastic candidiasis, I'm very, very wary whenever I get a diagnosis back of chronic hyperplastic candidiasis, as I do with any diagnosis that tells me that the lesion is a squamoproliferative lesion. Both of these diagnoses are very, very highly associated with oral cancer, oral squamous cell carcinoma, and really, if I get a chronic hyperplastic candidiasis or a squamoproliferative lesion back as a diagnosis, I do treat that as an early cancer, and may do an early, just a low resection on that to get a proper diagnosis. So the pre-malignant lesions that used to be called the leukoplakia, a straight leukoplakia or a white patch has a low risk of malignant progression. Erythroplakia has got a much higher risk of malignant progression, and the so-called speckled or mixed lesions, a lot of them are actually carcinomas when they first present. An oral lichen planus, straight oral lichen planus, has a malignant transformation rate of about 0.2 to 5%. And although it's always put down as a pre-malignant type lesion or condition, straight oral lichen planus probably is not as risky as some of the other issues. HIV, 2 to 3-fold increase in the incidence of head and neck malignancies. And we're seeing a lot in our hospital of solid organ transplantation, particularly the immunosuppressive agents or the anti-rejection medications that these people are on. The majority of these people develop cutaneous malignancies, and about 1% tongue and other mucosal sites. However, once they seem to get one, it does seem to progress, and we've just got a gentleman in our hospital at the moment who's really onto his 4th or 5th oral carcinoma following a heart transplant approximately 15 years ago. So other risk factors, increasing age, poor diet, nutrition, a lot of genetic factors, occupational exposure, and radiation exposure. In order to discuss any of these topics, we really need to have a look at what the normal cell cycle is and how the cell cycle is interfered with the various cytokines first, and then the carcinogenic agents, particularly in some of the mitotic phases and the mitogenic signaling areas and the synthesis phases of the cell cycle. And labile cells, such as epithelium and bone marrow, are the ones that are most at risk of these ongoing carcinogenic effects. So progression through each stage of the cell cycle requires this interaction between cyclins and cyclin-dependent kinases. And this is very important because interference with any of these can remove protective influences or can add in significant mitogenic influences. Tumor suppressor genes are activated when DNA damage is detected at the checkpoints. And so changing some of these tumor suppressor genes or the way they're activated can cause tumor development. So the cell cycle also contains DNA repair genes, apoptotic genes that cause the cell to die, and immune surveillance, which protects our body from changes in the cell cycle, where defective cells, and there are probably thousands of these types of cells generated at every cell cycle, but the body, through its immune surveillance, through apoptosis, through the repair genes, are able to get rid of these so they don't go on to cause tumours. So carcinogenesis in its simplest form requires initiation. So there are initiate cells that get past the immune surveillance and get past the repair mechanisms. So cells with unrepaired DNA damage complete a cycle of division in which the genetic mutations are copied. So therefore, this is cell one, as it were, the first cell that causes the tumor. And you remember, every single tumor, the tumor itself is a development of a single cell line. And this forms initiated cells. So once you have these initiate cells, you then can have promotion or clonal expansion. So every single cell is identical, and there aren't the normal mechanisms to prevent this cellular growth. So promoters stimulate these initiate cells. They lead to hyperplasia of both the normal and the initiated cells. So that's why these tumors start to look and proliferate. And there's an opportunity for further accumulation of multiple mutations. And then you have progression with tumor growth, with the increase in tumor size and development of malignancy. And these tumors are able to enhance or stimulate angiogenesis and the induction of stroma, leading to local invasiveness, formation of distant metastases. So these cells grow in places that they shouldn't normally grow. And as we've said, the hallmarks of malignancy, going back to the cell cycle, are self-sufficiency and growth signaling. So the cells grow without any boundaries. They are insensitive to growth inhibiting signals. They evade apoptosis. They have a limitless replication potentials, and there are a number of research cell lines, which are tumor cell lines, which are essentially the fountain of youth, eternal life. They have sustained angiogenesis, and they have the ability to invade and metastasize. So if you have a look at the main players in this, particularly in oral cavities, you have a gain in some oncogenes. So you have activation of epidermal growth factors, activations of genes coding for self-signaling. You activate cyclin D and E, and so you get cell cycle progression. And then you get loss of the tumor suppressor genes, so therefore uncovering or allowing these things to grow. The retinoblastoma gene mutation leads to release of transcription factors and DNA replication, and P53. So greater than 50% of primary head and neck SCCs have a P53 mutation. And this mutation leads to a decreased cell cycle arrest and DNA repair. And the incidence of this P53 mutation is much higher in smokers and drinkers. You get activation of telomerase, which is again the cell cycle, and this turns off apoptosis. So you get cell cycles just continuing to cycle. And early in carcinogenesis, you get deletion of this region of a chromosome, and this acts really as a tumor suppressor by binding to cyclin D1, and so it regulates progression through the G1 and S phases in the cell cycle, and then P16 inactivation leads to cell cycle dysregulation, and therefore moving to tumor. So the mechanism of HPV then differs to smokers and tobacco users, because HPV viral oncoproteins degrade and inactivate tumor suppressor genes rather than mutating them. HPV 16 and 18 encode for these two oncoproteins, which degrade P53 and riboflavin there. So P16 thus is a surrogate marker of the presence of HPV. So you can't measure the HPV itself, but you can measure the overexpressed P16 protein. And for those of us who are more than 18 that are on this teleconference, probably remember the World Health Organization through the 80s and Professor Pinborg and his work in dysplasia, hyperplasia, and the arguments that occurred really on what constituted mild, moderate, or severe dysplasia, really whether epithelium went through stages of hyperplasia, mild, moderate, and severe dysplasia, then to carcinoma in situ and invasive carcinoma. And really, probably the sequence is that there's a field change and the dysplasia occurs either as mild, moderate, or severe, and the invasive carcinoma occurs in that same area also. So these are the changes that occur in some of these areas, and in all of these areas there is genomic instability, and so therefore the opportunity for cancers to develop, and hence we're starting to develop the concept of pre-malignancy. In terms of patient assessment for all of these types of things, you need, as we were talking about in the previous, history is absolutely important here. What is the onset and duration of the lesion? What is the risk factor assessment? What are the symptoms? What are the constitutional symptoms? What does the lesion look like? And what does the neck feel like? And this goes through all of your both pre-malignant lesions and malignant lesions. In some of these, you may need to have panendoscopy. You may need baseline blood tests. You certainly will need some sort of imaging, ultrasound, CT scan with contrast, and then MRI. And CT with contrast is often, for most of these tumors is in fact the best assessment. Although now for extent, particularly tongue, we've started using MRI and PET-CT likewise. I'm sorry, I'm going through this a little bit quickly. I don't want to continue for too long here. But really, this is where I wanted to get to. Histology is still the gold standard here. So biopsy is absolutely required for histopathological assessment. And these are the white patches, the red patches, any sorts of lesions that you find here. So measure the lesion, photograph the lesion, ensure you've got an adequate depth of the lesion. And if the lesion is large, consider several biopsies from different sides, because as I've said, whenever I get a diagnosis of squamoproliferative lesion, I know that diagnosis is just an observation about what has been sent, and really other areas may well have different areas of either dysplasia or in fact frank carcinoma. So when we talk about the concept of precancer and the nomenclature, and then we have these potentially malignant disorders, as I said, I'm not going to talk about each one of these in a separate activity. So precancer in longitudinal studies are areas of tissue with certain alterations in clinical appearance that are identified at the first assessment as precancerous, and then during follow-up have undergone malignant change. So you go back and look at all of those follow-ups. This is what Pinborg did throughout the 70s and 80s. And you've got to remember, some of these alterations, particularly the red and white patches, are seen to coexist in areas of overt squamous cell carcinoma, and hence, the pathway of progression may not be as simple, mild to moderate to severe dysplasia to frank carcinoma. Proportion of these may share morphological and cytological changes that you do observe in epithelial malignancy, but without invasion. And these are the dysplasias. And some of the chromosomal, genomic, and molecular alterations found in clearly invasive oral cancers are detected in some of these precancerous or pre-malignant phases that these tumors went through. And some of the papers of this gentleman here, who I won't insult him by trying to pronounce his name, and Isaac van der Waal, who they worked together in the sort of 80s, 90s, and into the 2000s. So in terms of nomenclature, we used to think of precancerous, precursor, pre-malignant, intraepithelial neoplasia, carcinoma in situ. So these terms broadly describe the clinical presentations that have the potential to become cancer. However, it's unlikely there is uniformity, as I previously said, and I need to emphasize, in the way individual patients present or behave. Finally, the World Health Organization, after many years of argument, in 2005 came up with the term potentially malignant disorders. So these are all the lesions and conditions that may transform into cancer. They also convey that these are indicators of risk of likely future malignancy elsewhere in clinically abnormal or clinically normally appearing oral mucosa. So it's moved away from the previous classification of, some 20 years previously, of precancer lesions and conditions, so pre-malignant lesion and conditions. So they're all lumped now into this pre-malignant disorder. And just to round this off, let's just have a brief talk about leukoplakia, a white plaque of questionable risk having excluded other known diseases or disorders. And as you can see here, we've had a bit of difficulty with what constitutes a white patch. But finally, the World Health Organization tells us it's not defined, no distinction is made from other white patches. So the pre-malignant white patches are not different to other white patches. And leukoplakia should be used to recognize white plaques, not plagues, of questionable risk, having excluded other known diseases or disorders that carry no risk for cancer. So if you diagnose a white patch as something that is not leading to cancer, it's no longer a leukoplakia. It belongs to that condition that it is. And leukoplakia can be used at various levels of certainty. It can be a clinical term or a clinico-pathological term. Prevalence of leukoplakia about 2%. Again, malignant transformation 0.5 to 1%. 6 times more common in smokers, and this is again some of Pinborg's and Van der Waal's work. This is one of the hallmarks of smoking. One of the white patches, the hyperkeratosis, are hallmarks of smokers, and alcohol being an independent factor. So these homogeneous white patches, as you see in the upper photograph, are probably benign type lesions. However, if you have a look closely at that photograph, it is not homogeneous. The main white patch is homogeneous, but more anteriorly, there is a non-homogeneous second white patch that leads into it and some ruffling of the surface. So if the white patch is homogeneous, uniformly flat, thin, shallow, or is it non-homogeneous? And you could probably say that this lower picture is likely to be, even at presentation, a squamous cell carcinoma. This is a speckled erythroleukoplakia, mixed red and white, nodular, outgrowths, rounded, so verrucous. So this proliferative verrucous leukoplakia, multifocal, resistance to treatment, high risk of malignant transformation, because it's often thought that this is likely to be a malignancy at first presentation. It may not be a pre-malignant condition, it is a malignant condition. And the clinical subtypes have a bearing on outcomes. So the risk of malignant transformation varies, and the homogeneous, as I said, low risk of malignant transformation, non-homogeneous, high risk of transformation. And again, from Isaac van der Waal, this little flow diagram of how to treat leukoplakias, eliminating the cause, no possible cause, all have a biopsy, as if the lesions persist, all need a biopsy. And I'm happy to leave it at that at this stage. And I thank you very much for your attention. I hope I've tried to keep within the time frame. I apologise for going over also a very broad topic and a quick walk through pre-malignant conditions.
Thank you, Dr. Sambrook, for that. That presentation of yours, a very difficult topic to deal with indeed. As I think in Australia, it would be the same as in India. When you see a pre-malignant lesion, you do not know whether you should observe the lesion or you should intervene. So that is the question. I think there's only one question that has come up in the question box, which asks, after listening to your whole lecture, the question that arose is, how do you manage pre-malignant lesions, or how do you manage potentially malignant disorders? In effect, do you observe, or do you give them chemoprotective agents, or do you do a biopsy? What is your answer to that, Professor Sambrook?
I always do a biopsy. I don't think we can avoid doing a biopsy. And then again, some of these lesions are quite extensive. So, if you can convince yourself that, we haven't got malignancy present, but it's an extensive lesion, then close observation with continued biopsying, when the lesion appears to change. For smaller lesions, I would remove the lesions with a conservative margin. But oftentimes, people with pre-malignant conditions, you've actually got field changes across the whole of the buccal mucosa or the surface of the tongue. And yes, you can remove large surfaces of mucosa, but wherever you stop, oftentimes there's an area that you need to find. So biopsy, ensuring there's not malignancy, and then close observation. And sometimes I would see these people 3 monthly, but certainly 6 monthly. But if you've got a smaller homogeneous white patch, again, cut it out. It's less of an issue, but it's really those wide areas, non-homogeneous, a little bit verrucous at times, smoker. You've really got to be concerned that at some stage they're going to put a real significant neoplastic process.
Fantastic. Yes, Professor Sambrook, the challenge here is that the lesion look very innocuous, unlike the previous speakers who spoke about bleeding, which looks very dramatic, and the patient needs treatment, but a potentially malignant disorder looks very innocuous. And many a times the challenge is that the patient does not come back for a follow-up because it does not worry him. So I think patient counseling is also a major part, plays a major part. And as you said, the area, more than the larger areas, heterogeneous appearance, erythroplakic appearance, I think these are all highlights on the higher risk of this lesion turning malignant. Isn't that right, Dr. Sambrook?
That's correct. And there's another question there about antioxidant tablets and various creams and things like that. We've gone through these phases of rubbing all sorts of things onto them, taking tablets, and really we haven't come up with a good solution, because this is a heterogeneous group of conditions. It's not just a single condition, and really, as we've said, education, close follow-up, biopsy, and is really the mainstay of treatment of these.
Yes, sir. And what do you think about field cancerization, sir? That's another challenge, right?
It's very much
field
a challenge.
Cancerization.
Again, they might pick up a small T1 and you treat that, and you might treat it aggressively, but it doesn't matter how aggressively you treat it, it's still, the margins may have dysplasia or there's field changes.
Exactly.
You may or may not do a neck, or you do it, a conservative cancer procedure for a T1, and then another one will come up a few years later. A few years later, another one comes up, and then oftentimes, I found anyway, you seem to get a massive one that will pop up.
Got the point, Professor Sambrook. This challenge is global, we understand. And if we have to discuss, we can keep on discussing. So I think we should move on to the next panelist. Thank you very much, Professor Sambrook. So over to Professor Vijay Kumar, who's all set to talk to us on an overview of the management of oral cancer. Professor Vijay Kumar, over to you, sir.
Thank you. Good afternoon, everybody. It's actually a great pleasure to be in midst of all of you. And this talk I have prepared for a very average young student as I was, and not for a learned audience. So they should pardon me for going from the scratch. Number one, you would be wondering why I chose this topic to be spoken to you people. Number one, you all know, most of the youngsters may or may not know, that we are one of the largest producers of oral cancer in the world. We contribute to more than 1/3 of the global burden of oral cancers, that is Indian subcontinent. And even today, we see the highest incidence of oral cancer globally, that's in India. So you also know why of it, although Professor Paul very eloquently spoke about the etiology. One important thing from our point of view, all who are working here know it, that is the smokeless tobacco and the chewing of tobacco. We taught the world how to use tobacco without smoking. So that is the main reason, although HPV is coming up, but the usage of tobacco has been considered as one single reason for oral cancer. The second reason is, when I was heading the Department of Oral Oncology in Kidwai Cancer Institute, for those of you who may not know what it is, it was a regional cancer center and now upgraded to the State Cancer Institute in Bangalore. We used to see 1,000 to 200 oral cancers per annum, biopsy proved, 1,200 oral cancers. And most of them come in such an advanced stage, I used to feel every day miserable. And I have to do something for that, I thought. And I have done quite a few of things which is not the part of the discussion today, starting from one side, the early detection activities to the clinical trials on the locally advanced disease. Today, I want to sensitize an average dental student and a dentist that how he has to approach an ulcer, which he may think it is innocuous. And that was the basic reason I accepted it. But at the same time, just talking about very basic level may not be useful. So I'm going to give an overview of the cancer management, oral cancer management. And it is most of the time what we are talking is the way in India most of us do it. And I am very sure all the senior colleagues of mine from India will accept what I am going to talk, because it's basically this. I suppose my slides we are able to see. I don't know, because I just shared the slide. I hope you are able to see the slides. Hoping that, I'll quickly thank all the organizers for inviting me to be a part of this management for this program, and also mainly Dr. Gibson, who wrote to me to be a part of it. Thank you very much for doing so. I spent about 35 years in cancer, and I came out of the Regional Cancer Center to set up a cancer institute in Yanapaya, deemed to be university, with the support of Tata Trust, and we are establishing a comprehensive cancer setup. That is my background for which I am talking. The most important one which I would like to stress on the slide for a young student would be, don't look at the tumor alone, look at the patient as a whole. ECH, the performance status and organ system are going to dictate, although you may have everything under your sight. You may have surgery, you may have radiotherapy, etc. But you may have to know there is a patient whom you are treating and not the disease per se. Coming to the treatment, very eloquently Professor Paul has covered the etiopathogenesis, etc. and the pre-malignant and the lesions and the pre-malignant conditions, which is recently redefined as the potential malignant disorders. So I'll just take away from him from where he left. It's easy now for me to go in a continuum where the treatment actually starts with prevention. Primary prevention is what I was trying to stress on saying that tobacco, don't use tobacco, you don't get cancer. If you can do that, it is primary prevention. Prevent the exposure itself. Secondary prevention is it has happened, but you are going to detect it early, and that is secondary prevention. Again, it is very effectively can be done. Oral cavity being a very easy organ and superficial organ to just to open the mouth to see. So today we are going to concentrate on the tertiary prevention, that is nothing but the treatment of an established disease. For the benefit of the students, as eloquently asked by Professor Reena, that is when it comes yearly, that is the time it's a challenge. It may come as a very small, different texture, different color changes. Many times is the asymptomatic. In a very early stage, that's how it comes. But unfortunately, in India, most of the cancers come very late. According to the ICMR data of 2016, published in 2017, all cancers, it's not oral cancer, all cancer treated in India, only 12% of them or less than 12% of them come in the early stage. That is the most painful thing to know about it, because all our efforts, money, time spent on them will go waste unless they come early. Such a potentially curable disease is cancer of the oral cavity, but they reach us a little late. And if they are late, we are going to have a problem, they are going to have a problem. Most of the time, what they present to us is well known to all of us here from our country. There's a large mass or an ulcerative lesion, loss of function, trismus, etc. From the benefit of the students, the primary lesion is going to be either an exophytic, that is proliferative lesion, or an endophytic or an induration lesion. Most of the time, it is combination of both. So it will be ulcero-proliferative or ulcero-infiltrative. That is, endophytic lesion is more induration is endophytic. The more proliferative part is called as exophytic. But most of the time, it is a combination of both. Most important one I would stress here would be a bidigital examination. A clinical examination is one I will keep on stressing and again, because imaging comes much later. Whereas the clinical examination is the most important one, which can easily diagnose visually, that is by inspection, and by palpation. You can make out whether it's locally advanced, etc. Then comes the regional nodes. Regional nodes of the neck, again, one-sided neck is called as regional nodes for that, but many of them present with nodes. Many times they are positive in our country, and so that the examination of the node is also important. As we move on, we'll see. In the clinical examination of the primary tumor, the staging is mainly by clinical examination, by the bidigital examination, till it touches the bone. The moment the bone is involved, or the tumor is very close to the bone, then comes the help of our imaging. And the imaging, conventionally, we used to do olden days skygram. No more it is done, because the sensitivity is poor. It has to have at least 30 to 40% destruction to be picked up by the conventional skygrams, and so we don't do. But orthopentagram is done routinely even today. That is mainly to know the minimal involvement. Also, the depth of destruction can also be made out. Whether the canal is involved or not can be nicely made out. And also for comparing with the contralateral side, for us to decide about the replacement if it is required. But more often done is the CT scan for the bone. For the bone, the most important one is the high resolution CT scan, which can pick up nicely. There is always a controversy or a confusion for the student point of view, whether they will ask for a CT scan and MRI when it comes to the oral cavity. So the thumb rule conventionally is simple, that for a bone it is CT scan, for soft tissue it is MRI. And for example, bone marrow involvement can be picked up better by MRI than CT scan. But we can't be doing all the tests and all the scans in everywhere. But for our knowledge, MRI is very important in the tongue, because when the deep infiltration can be picked up by MRI over and above the CT scan. In all other places, CT scan is good enough. And it has been already touched upon by him. Coming to the nodal disease staging, clinical staging is the most important. As I said, it is palpable, not palpable. Once it is palpable, whether it is mobile or fixed, I'll come to that. Earlier, it was not given importance to in the staging system. Currently, it is given. Then comes the size. Size is, even today, it is given importance to, whether it is less than 3 centimeters or more than 3 and between 3 and 6 and more than 6. Even today it is given. And it increases the staging by N1, N2, N3. As we go on, we'll see. But the more important problem is how to prove them when they are clinically non-palpable. A clinically non-palpable disease is what is more an important problem for us, because whether we have to go and do or not. I did a small study when long back, maybe 25 years ago at Kidwai, just to know what is happening. N0 non-palpable disease, I just did comprehensive neck dissection. I'm talking 30 years ago. And then we saw what happened to them. You won't believe me, at least 50% of the time, irrespective of what is the primary status of the T, etc., and the subside, it was positive, making me feel that N0 clinically is useless. But at the same time, you look at the other side, 50% of the times, it's an unnecessary surgery. So then we thought, why not we take the advantage of other imaging? When you try to do that, the CT scan, as I said, resolution rate or the accuracy rate is around 60 to 70%, and MRI rate is around 70 to 80%. And only to my own surprise, the high frequency Doppler, high frequency ultrasound had the best result. But the problem with high frequency ultrasound is availability of the high frequency probe, and secondly, more importantly, the time and expertise and the patience required out of the observer, because it is observer dependent. That is the main thing. And the most important thing came out was depth of invasion as a pathological marker. When it is more than 4 millimeters depth, they felt that the nodal disease, even in N0, turned out to be positive, was high. And what did we do for that? This is our own study, which I did in Kidwai and published the data. It is in 2011, wherein we actually took oral tongue, anterior two-third tongue. As I said, the number was huge in that place where I worked. And in fact, in the 5 years, it was somewhere around 1,400 cases, see a tongue biopsy proved. But for this study, what I have taken is only N0, that is non-palpable neck nodes. So in that study, what I did was I addressed the primary only for the sake of the study, and then send it to the pathologist asking for the depth of invasion. And when the depth of invasion were more than 4 millimeters, I addressed them with surgery, neck dissection. And to my surprise, most of the time they were positive. It's a published data. You're welcome to see. It's around 70% of the times they are positive, and only in 30% of the times we felt that they were not positive. But our problem would be whether to go with 70% or 30% was the issue, which was, of course, well addressed by my colleague from Tata Memorial, which I will be talking later. The oral cancer staging, this I want to stress for the students' sake, because till 2017, it was easy to remember. Less than 2 centimeters is T1, 2 to 4 is T2, more than 4 is T3, adjacent structure involvement was T4. It's so simple. But the depth of involvement was now, infiltration was now added, where, of course, I'm happy that my own paper was talking about in 2011. But the problem here is how to assess this pre-operatively, making a case that this cannot be used, according to me, in a pre-operative setting to make out a depth of invasion. Other senior colleagues who are sitting there may throw some light on it. Post-operatively in a PTN now, yes, depth of invasion is possible with a micrometer, with a pathology microscopy. But pre-operatively, I don't know how to make it. Clinically, particularly when it is subtle, it's easy. Very thick, it is easy. Whereas in between, saying that it is whether it is 5 millimeters only or less than 5 or more than 5, it is difficult. Coming to the nodal status, it was also easy. Single, less than 3 centimeters, more than 3 and less than 6 was N2, and more than 6 was N3. And ipsilateral, contralateral, bilateral, multiple were taken into account till 2017. One extra thing added, which is according to me is also very good, that is the extranodal extension. The pericapsular spread was not given respect to till that time. Now, if there is a pericapsular spread, so-called extranodal extension, it automatically becomes N3. That's an important change which has occurred in the TNM staging currently. And of course, the staging system is a combination of everything. In our own colleague from Dr. Subramaniam and Subramaniam Iyer from from Amrita Institute in Indian Journal of Cancer has compared that critically and seen whether the 7th and 8th edition, how far the 8th edition things can be implemented in an Indian context. It's worth going through an article. Coming back to the management part, most of the time the confirmation is done by biopsy, all of you know, so I'm not going to insist on this slide much more, but remember, an incision biopsy on the periphery is much more productive than taking a slough in the center of the biopsy. This was again told, but for the benefit of the students, squamous cell carcinoma is the so commonest cancer, and so when we say oral cancer, by default we are talking about oral squamous cell carcinoma, unless specified otherwise, it is squamous cell carcinoma. It's so common. On the other side, rare. Melanoma is very rare. I had a series of 12 cases published, and any type of minor salivary gland tumors can also be there, and sarcomas, even rarely lymphomas can present. Coming to oral squamous cell carcinomas only, management if you take, basically it revolves around only two modalities. One is surgery, another is radiotherapy. Both are complementary to each other if you ask me. And you will look at this slide. I want particularly the surgical group who are attending today have to see this. I have been training orofacial surgeons for the last 20 years or so now. Whoever comes to me in oral cancer or ENT stream or general surgery team, I train them. The simple reason, the oncological principles have to be taught very early so that they should not think radiotherapy is competitive to surgery, but it is complementary. Yes, it is in a simple T1 disease, both are curative and either of the two can be used. But most of the time in our country, it is T3, T4, so both have to be used together, one after the other. We'll go on, I'll tell you. If you take surgery, it's a very fancied thing for many of us to do. But unfortunately, bigger surgeries have now taken care of, and we are now landing up more and more less surgeries, less radical surgeries. But at the same time, oncological principles have to be maintained. This is possible for two reasons. One, they are coming early, probably. We will be able to do that. Two, we are able to downstay them and offer surgical treatment, so we are able to do. Third most important thing is we have understood the biology by doing bigger and bigger surgeries without realizing how much cut margins you have to give. It's only a waste. 1 centimeter margin if you can give, that is more than sufficient, and as long as you get the cut margin negative. So when you try to do an unstretched margin, it's difficult. So you'll be stretching and operating. So I always tell my boys that they must give at least 1.5 centimeter to get the negative margin pathologically positive. The only aim of surgery in cancer everywhere, including oral cancer, is to get a negative margin. Beyond that, we cannot change the biology of the disease with surgery. So what is the aim of treatment as a cancer as a whole, particularly in oral cancer, when you are dealing with an organ which has got functional problem and cosmesis, they will ask. The most important and probably the only reason for which the patient has come to us and you are treating is oncological control. What is the second aim? Oncological control. What is the third aim? Oncological control. If the oncological control can be achieved, then you think of the functional part, and the lastly only you have to think of cosmos. This is in a puristic sense I am talking. Whereas when a patient approaches us, the person is going to ask for everything. The patient is going to ask, yes, it is cancer, you have to treat effectively, no doubt, but at the same time, you have to take care of the function, that is speech and swallowing, effectively, and more importantly, it is in the exposed part of the body, face, and hence the cosmesis also comes into the picture. That becomes a challenge. But still, I would say oncological control first, functional control next, third only is cosmesis. And for those people who will be fancied with some things happening here, there are people who have started talking about the access, etc. But we are now cut it off. See, ultimately, our aim in surgery is to get a cut margin negative. Whether you achieve it with a cold knife, with a cautery knife, or a laser does not matter. But I think it is working. So I'm not going to show this whole thing. It is only to just create some interest. So this is actually a laser non-contact laser, carbon dioxide laser. We are using it to do a hemiglossectomy. The point is not that, just to make people understand that what we use does not matter, but what we achieve is what it matters. That is, you have to get a margin negative so that the pathologist should be able to tell that it is clearly yeah. Coming to the mandible, this is another one which I will try to concentrate. Mandible was routinely removed even though it was a bystander about 50, 60 years ago. Today, no. We remove what is involved and how much is involved. Minimum requirement, what is to be removed is only removed. What is the minimum requirement is again 1 centimeter normal bone on CT scan, clinically and by scan wise, and it should be normal. The marrow again should be normal. If you can give this much, 1 centimeter clearance is more than sufficient. So we have moved from the days of hemimandibulectomy to segmental to marginal. But marginal was introduced mainly in the beginning for diseases which are falling, mandible falling within the 1 centimeter clearance of the disease. Whereas now, even for minimal involvement without major erosions, we are contemplating marginal mandibulectomy, where organ preservation and function preservation becoming a more important assay and is supported and backed up by post-op RT, which we'll talk. Most of the time, because of the cosmesis, transorally, we are going to approach all these cancers if that is possible. Otherwise, we have to go to the cheek flap. Very rarely nowadays we do other things for a oral cavity. Mandibulotomy, etc., are done only for posterior lesions and oropharyngeal lesions, not for the classical oral lesions. Coming to the neck, the classical neck dissection today, what we call, was called as radical neck dissection by John Cryle when he introduced 1906. And even today, it is considered as a gold standard by many as a therapeutic procedure. What do you mean by therapeutic procedure? It's a large proved node. We are going to do the dissection to remove the disease. So it is called a therapeutic. What do? We remove level 1, 2, 3, 4, and 5. Once we remove all these group of lymph nodes along with non-lymphatic structures like accessory nerve, internal jugular vein, and sternocleidomastoid, that becomes a classical neck dissection. Whereas today we try to preserve certain non-visceral structures, and that becomes the modified neck dissection. What is SOND or supraomoid neck dissection? It is a staging procedure done today for N0 for level 1, 2, and 3 are removed for oral cancer. And then I just diagrammatically or operative surgery wise, I'll try to show what it is. It is, yeah. See the, you know, yeah, I'm having some problem with the sharing, but I'm doing it. So this is, again, I'm not trying to show the whole surgery. I am trying to show what it looks like at the end of the procedure. We are trying to remove the whole disease, and then you will see what it is to understand. Yes, this is what I am trying to stress on, that see the neck after removing, completely denuded of the fibrofatty tissue, lymph bearing tissue along with lymph nodes is removed. Level 1, 2, 3, 4, and 5 are cleared. We are only denuded muscle, nerve, and vessel is maintained. And as you see there, we have only got the carotid, internal jugular vein having been removed, accessory nerve being removed. This is the classical neck dissection. And next we will see the difference to make you understand. You can see the difference. I am just trying to show the modified neck dissection just to show the field how it is different and what we have to do for that. The modified neck dissection or type 1, 2, 3. The type 1 is where accessory nerve alone is maintained, and type 2 is where accessory nerve and internal jugular vein are maintained and preserved, and the type 3 we retain all the three. And again, I am not trying completely showing that, but this is just to show what we are trying to see. See, this is the accessory nerves. There you are seeing the accessory nerve here. You can see that, and the internal jugular vein is seen here. And more importantly, at the end of it, you can see the difference now between the classical and what we are now trying to show. That is the, see, once the disease is removed, this is what I was trying to show. This is the MND type 2, where the whole of the internal jugular vein and accessory nerve is maintained. What I am trying to stress is we need not do a classical neck dissection. At the same time, the clearance should be adequate. We have to give a proper clearance, and then only we can claim that what we have done is the therapeutic neck dissection. On the other hand, the supramyoid neck dissection, which I already classified as staging neck dissection, is done for N0 basically, and we are doing it for N0 oral cavity, particularly buccal mucosa. There is no confusion where level 1, 2, 3 are taken away. And again, I am not trying to completely show the pictures or the. I am only trying to show what we have removed, and it's level 1, 2, 3 clearance. All right. So it is level 1, 2, 3 clearance. You can see the accessory nerve coming into the from top down. You are seeing the digastric being shown, and the sternomastid is being retracted. Actually, what I am showing is called a submuscular uses of Boca. You are seeing the internal jugular vein, and once this clearance of level 1, 2, 3 is done, then we are trying to call it as supramyoid neck dissection. Three neck dissections are one which every student should remember. One is classical neck dissection and the modified ones, that is MND type 1, 2, 3. And the other one is the supramyoid neck dissection. And this is what we are going to stress on when it comes to management. In simple thumb rule would be N plus means I'm talking clinically and radiologically plus positive notes. If you are sure by say FNAC, then what we are going to offer is a therapeutic lymph node dissection. Level 1, 2, 3, 4, 5 are removed. Whereas on N0, we are going to do a staging neck dissection. Coming to the reconstruction, which today I will not be able to cover the whole thing, so I am only going to give an overview of what reconstruction, soft part and bone, I am going to tell. Short part starting from direct closure to free tissue transfer. Today in our setting, free tissue transfer, if you are doing it, is the Chinese forearm flap is become standard. As far as then the bulk is concerned, we use a pectoralis major myocutaneous flap more often for the sake of the bulk. Whereas for the bone, we can use a bone anything, but we are now, if a bone is used, we always are using fibular graft, microvascular free graft as a replacement. Today has become the so-called standard, though there are so many other things we can use. And when it comes to bone defect, one question will come whether we have to reconstruct every case every time. Answer is no. A central segment, it is mandatory. For lateral segment and ascending ramus, it is optional. But most of the patients today, they are asking for function and cosmesis, and that makes a case for even lateral and ascending ramus. We do the reconstruction routinely. Coming to the treatment by stage, this is what is a conventionally spoken of. T1 means what? Either surgery or RT, and T3, T4 is surgery plus RT. Coming to the N0, as I said, wait and watch was considered to be one of the options, which I'm going to negate later. And the SOND is done as a routine to know whether it is positive or negative. And when you move on to this, what is the risk group? Which group you will observe? Which group you will operate? You may ask. So the group which you are talking about, high risk group, will be by stage. Site would be the floor of the mouth, oral tongue, and retromolar trigone become high risk areas. where more than T384 becomes high risk is more, and hence we are going to do. And if the depth of invasion is known, again it is high risk, more than 4 millimeters becomes high risk. Whereas this issue was settled recently by my colleague friend from Tata Memorial Hospital, Anil T. Cruz, whose paper is a very well done, where 700 plus patients were randomly divided into 2 arms, where the elective neck decision at the time of primary surgery was conferred. For other people, they were observed for a clinically negative node, that is N0, which I said in my study also in 2011. And in this, they have proved that there is a definite role for elective neck dissection, even for N0, that probably settles the issue today in India, at least. Whether you will address the neck or not, if somebody asks, we can boldly tell, yes, you do a neck dissection, you'll have to do for an N0. The prosthodontics and speech and swallowing rehabilitation is important. I need not tell you, people who know much more than me. This is one more thing. We have got the NCG guidelines, etc., NCCN guidelines, whereas we back in India in 2017, the NCG guidelines have come out. A few may know, many may not know. NCG is National Cancer Grid, supported by the Tata Memorial Hospital and sponsored by the Department of Atomic Energy. It is spearheaded by Tata Memorial Hospital, under which almost 180 centers are there, and we came with this consensus, and we have come out for these guidelines for many cancers. I'm only talking today oral cancer 2017. This makes a Bible for us in India because it is workable, practical, and feasible at the same time, not moving away from science. And this is what I would like to attract your attention of the youngsters, that there is an NCG guidelines which is there on the website of NCG. Before I complete, we have talked so much on surgery. As I said in the beginning, radiotherapy is equally important. So when do we prefer radiotherapy? Primarily, as against surgery. Obviously, as I was stressing on, if cosmesis was worried, function, in all these cases, you will be thinking of radiotherapy over surgery when both options are available. And also you must look at a local facility, what is available, not available. And for exorbitant lesions and poorly differentiated, we would prefer RT over surgery. Coming to the primary site, you see the lip. It is easy for us to do surgery, no doubt, but unfortunately reconstruction and cosmesis and function is a problem, and hence radiotherapy is preferable. It is interstitial brachytherapy is given. For floor mouth, it is intraoperative cone beam radiotherapy is given, and tongue, external beam radiotherapy versus brachytherapy, and buccal mucosa, you can do both. When will you do post-operative radiotherapy? Somebody may ask, after the surgery is done. As I said, T3, T4 disease, most of us we give. The positive margin, surgical margin, definitely it makes a case, but it's a poor indicator of surgery. But the only way to salvage would be surgery, radiotherapy. If you cannot go back and revise, many times it is not possible. And if there is a frozen section positivity, although you would have revised, we still give radiotherapy. Perineural invasion, node positivity, lymphovascular, all becomes an indication. Coming to the nodes, multiple nodes, perinodal spread becomes an indication. One word of caution is, in perinodal spread, when it has happened and cut margin positive, we not only give radiotherapy, we give chemoradiotherapy. That is, combining chemotherapy with radiotherapy is what we do, and this is what is routinely followed all over. This I want to keep for 1 minute for the benefit of my young students. You can click it. This has been brought out as a book for you people, and you can use this and download it. It is free for you. Because I made it as a pocket book because I want oral cancer to be a pocket book now in India, not as a reference book. And particularly for dentists, keeping a dentist and oral surgeon in my mind, this book was written. And in fact, it is Karnataka State Orofacial Surgeon Chairperson Dr. Sripati Rao has given the forward for this book. And it has covered A to Z of everything spoken today, starting from epidemiology to palliative care. I would request the students to take advantage of that. Before I conclude, I thank you once again for the patient listening and giving me an opportunity to be a part of this program. Thank you.
Thank you, Professor Dr. Vijay Kumar, for that exhaustive and yet so clear and crisp that you have put forward to us on the overview of the management of oral cancer. Absolutely enjoyed it, sir. I'm sure it was helpful for all the youngsters who have listened to you. And thank you, sir, for training young maxillofacial surgeons under you. So there are a few questions, sir, just one or two questions. Can I ask you, sir, though we have overshot time?
Please.
Sir, is there any difference in staging of squamous cell carcinoma of buccal mucosa according to the Indian Medical Council? I'm not aware of it.
You are talking about staging?
Yes, sir. Staging. There's a
Staging,
question on
no.
that staging.
We all
No.
follow only one staging, that is
Yes, sir.
staging, as it's, I mean, what do you call it? Updated and revised. The latest revision is in 2017, which came into vogue from almost 2019 onwards. It is called as 2017 guidelines, but all started using it from 2019 onwards. And I also pointed out some of the problems of using it, but that apart, that is the science controversy will continue. We may write to them, etc. But what we follow is TNM of HSC 2017 guidelines only.
Yes, sir. Thank you, sir. Sir, and there was a question on the metastasis from the tongue, sir. I think the person who asked the question wanted to know which levels of the neck we would manage in a T1 lesion of the tongue, T2 lesion. When will you go for a contralateral dissection? That I think that is what they had in mind when they asked that question.
Number one, I thought I made it simple. Making thumb rule is very easy. I told N0, do a staging neck dissection. Staging neck dissection is level 1, 2, 3. This is what oral cancer as a whole we do. For tongue, they give us some exceptions by saying that you have to do an extended SOND that is covering 1, 2, 3, and 4. That is all. Beyond that, there is nothing that we are going to add. But the main problem would be not whether level 1, 2, 3 on ipsilateral. What do you do for the contralateral? Contralateral, when it is N0, we don't touch it at all. Only one reason we will do it is the tip of the tongue or the tongue primary when it is crossing the midline. Then we are worried that the contralateral may also be involved. And so most of the time this happens with the N plus node on the ipsilateral and N0 node on the contralateral.
Exactly.
Then the question comes, and most of the time we will address that by an SOND as though that is a part of the primary. If there is a bulky node sitting here, and more often, whether it is proved or unproved, we follow a thumb rule. If the submental nodes are enlarged and positive, then the chances of the contralateral having it is very high. And so then also we will try to do a staging neck node dissection on the contralateral side. Otherwise, we concentrate on the ipsilateral and ipsilateral only, hoping there are no disease, number one. Number two, even if it is so, most of the time, post-op radiotherapy, which is given, always they cover the contralateral side also.
Thank you, sir. Thank you, sir. I think that was asked by Anum Rana, and he or she has re-asked that question in the sense he wants to know whether it metastasizes to the thyroid or not. That is what
answer is
clarified. No, it does not metastasize. No. Yes, sir. Yes.
Thyroid is a different organ, different fascia, different level. Thyroid metastasis doesn't happen, or we don't accept it as a common occurrence. We don't address.
Okay, sir. Thank you, sir. There is one more question. I know we have overshot, but we still have more than 400 participants still stuck to this place. I'm sure they want to listen to you. So I am taking the liberty of asking you one more question, sir. Your opinion on sentinel lymph node biopsy has been asked by Saravanan Gopalan. Your opinion on sentinel lymph node biopsy?
I have two answers for that. The sentinel node is upcoming here, no doubt. Most of the time it is being propagated by, I would say, West. The reason is very simple. For us, as I said, I told my data as well as the ICMR data, less than 10% of the cases only we are looking at N0. So we are going to do it only in the 10% of the cases only. Whether to do sentinel node or not comes. In all other cancers, it is positive node. We have to do therapeutic neck dissection. This is number one. And in the 10% of the node dissections, when will we do? And you ask, I already explained the low risk business, but sentinel node is an upcoming thing. Quite a few people start doing it. Why people like me don't want to do it is very simple. As against in other places where it is propagated. For example, in breast cancer, Sentinel node is a done thing. In the inguinal region, it is a done thing. For simple reason, if you try to do unnecessarily a dissection, the lymphedema is the answer. And it's a severe lymphedema sometimes occurs in the lower limb. And so they try to avoid if that is possible. Whereas in the neck, I don't see any lymphedema occurring. And even and in my earlier days, I used to do bilateral neck dissections, stage, unstage, etc. They are more therapeutic, and the edema occurring after the SOND, particularly the limited neck dissections, is rather unknown to. So trying to do something unnecessary is one point. Second most important point is technical. When you try to do a primary disease, many times when they are bulky, the disease plus the node looks the same as far as the activity is concerned. That is going to confuse the issue. And the third most important thing is, what are we really trying to achieve by avoiding an SOND, which can be done in half an hour, is very limited for me to say a sentinel node as a role. But as a study, many of us are doing it. Many of us may come out tomorrow also how it is useful. But as of today, it is only limited to protocol study, but it is not the standard.
Thank you, sir. That was very clear, sir. One last question, sir. Can we use the MRI for measuring the depth of invasion, especially for the tongue?
I asked that question to you all because I have done my own study on that. I have done an ultrasound, high frequency ultrasound for tongue, and that is my study, of course, comparing with MRI with clinical. That is clinical thickness, MRI, ultrasound, high frequency. So MRI is considered to be superior, no doubt. And ultrasound, if you ask me, in our hands, it will be better, but I won't accept it because, as I said, it's an observer dependent. And so the time consuming, many of the ultrasonologists may not have that much time, and that 7.5 megahertz may not be available in the routine ultrasound room. What they have is only 3.5 to 5. So this is another issue. So MRI becomes the standard now for measuring the depth of invasion short of anything else. But the problem here is depth of invasion, I'm taking half a minute extra, is defined today is not equal to tumor thickness. Tumor thickness is thickness from the uppermost part of the lesion, disease, to the lowermost point of involvement, infiltration. That is tumor thickness. Whereas depth of invasion, by definition, is from the basement membrane to the lowermost part. So according to me, MRI or clinical, anybody cannot make out depth of invasion if you go by that definition. So it is pathology, and pathologists only can say that. If you are going to use it loosely equivalent to tumor thickness, then it is possible with MRI.
Dr. Reena, you are muted.
Sir, nice to see you, sir. Dr. Veerabahu, nice to see you after a long time.
After a long time, eagerly listening to you, sir, from Trivandrum.
Thank you, sir. Thank you, sir. Thank you so much for that presentation and answering our questions. It was wonderful, sir. Thank you very much.
Thank you very much once again for everybody for giving me this opportunity. And also for the 400 plus stage on a Sunday till 5 o'clock. Thank you.
Thank you, sir. Thank you.
Thank you.
Dr. Jimson.
Thank you. And I'd like to thank all the speakers, Professor Andy Edwards, Professor Paul Sambrook, Professor Vijay Kumar, and Professor Veerabahu for spending your valuable time. Yes, I know we have exceeded the time limit, but and all the participants who have stayed glued to the presentations for close to 3 hours. So it was, so that shows the interest that these speakers have generated in their talk, and I think I don't have to say anything more than that. So thank you all for the fantastic presentations, and our editor is here, Dr. Kannan. If you can give him a couple of minutes for him to show the newsletter. Kannan, are you there? Kannan?
Yes, sir, I'm there, sir.
Oh, yeah, you're driving. Okay.
Yes, sir. I just stopped around. Yes, sir. I'll go for sharing the screen, sir.
He has spent quite a lot of time in preparing the.
Yes, sir. Is my screen visible, sir?
Yes.
Yes, sir. So good evening, everyone, sir. Good evening, everyone. So sorry for the initial hitch at the beginning of the program. So I was not audible and I was not able to share it properly due to the technical hitch. And I take pride in sharing the 4th edition of the newsletter for Tamil Nadu and Pondicherry chapter of the AOMSI. Supposed to have been released by October, November due to the COVID pandemic got delayed. And following the footsteps of Dr. Arun Kumar under the able guidance of Secretary Dr. Jimson and President Madam Dr. Reena Madam. So I'm releasing. I'd like to mention a special word of thanks to Dr. Vimalambiga, who's been helping me in bringing out this newsletter in every aspect, helping me out. Thank you, Dr. Vimala. So I'll just scroll through the newsletters. So this is the cover page, and followed by obituary to due to sad demise of the pioneer Dr. CKD sir, and obituary messages from the association, followed by the messages from people close to him, and the office bearers as usual. Messages from the president and secretary of the national body, and then president, secretary, and editor of our national body. So here, Dr. Prabhu has explained how the growth of the Tamil Nadu and Pandit chapter in our state, of the AOMSI in our state, how it progressed and how they developed it. And thanks to Dr. Jimson, the series of the webinars. Here's a list of the webinars and people who have participated, the panelists, the webinars, and the Ask Your Mentor programs. And something related to an article by Dr. Kannan Balaraman, who discussed about the difficulties that we overcame during this pandemic of COVID-19. I'm sorry, the next slide. Sorry. The coming slides had included so something new this time. So some artistic and literary work we have included. So these are the cartoons from Dr. Balaji from Chennai. And here we have included a poem by our very own President Madam, Dr. Reena Madam, and few artworks by the staff, the postgraduates and some faculties, and a crossword puzzle here for the postgraduates particularly, and the upcoming event. And in the forthcoming issues, we are planning to introduce some interviews from experts, and some interesting case discussions, case reports, maybe are interesting articles. So I'd like to thank you once again for giving me this opportunity. So we'll be sharing this in a group later by Dr. Jimson. Thank you, sir.
Thank you, Kannan. You've done such a wonderful job. Congratulations.
Yes. Thank you, ma'am. Thank you, ma'am. Thank you, sir. Thank you.
Thank you, Kannan, for the wonderful work and the compilation.
Thank you, sir. Thank you, sir. Thank you, sir.
Which our association has been doing. And
yes, sir.
Thank you, professors, again for having spent your valuable time Sunday. Thank you. Participants, I have shared the feedback form in the chat box. So kindly fill in the feedback form and you will receive the certificate the next few days. And I would like to place on record a deep sense of thanks to Stryker. As always, they have been very kind enough in supporting all our programs. Thank you. Have a great Sunday evening.
My special thanks to Professor Andy Edwards and Professor Paul Sambruk who have been kind support to us. I think we are going to give you honorary fellowship or membership of IOMSI. Thank you so much.
Thank you so much.
Especially it's a Sunday, you have been very kind enough to support us.
Thank you so much.
Thanks very much, everybody. It's always a pleasure, as Paul knows as well. We're very, very grateful to be invited. We have very much long memories, happy memories of our Indian colleagues. And hopefully we'll meet again in more pleasant times, basically.
Yeah,
yes.
Thank you.
Absolutely.
Take care.
Thank you.
Have a nice Sunday at
Thank
the
you.
evening.
Thank you.
Thank you.
Have a great
Bye.
day.
Bye-bye.
Have
Bye.
a great day. Thank you. Thank you.
Thank you, Jim. Thank you, GPK. Thank you, sir. Professor Vijay Kumar, sir. Thank you.
Thank you, Dr. Thank you, Professor Vijay Kumar. Thank you. Thank you. Thank you, Dr. Veera.
Thank you. Thank you.
GPK, Dr. Jimson. Thank you.
Thank you, Dr. Jimson. Thank you.
Thank you.
Thank you, GPK. I'll call you.